A very good evening. I welcome you to this evening. I extend my warm welcome to our extinguished guests to the Clinics in Hepato-Biliary Diseases 2022. I request sir to please be seated. To begin this evening, can I please invite Dr. Anil Arora? Sir is the course director for this event, and sir is a gastroenterologist, hepatologist, and he's also the chairman of Institute of Gastroenterology and Pancreatic Biliary Sciences, Sir Ganga Ram Hospital. Sir, can I please invite you on the stage?
Good evening to all of you. Let me extend a very warm welcome to all of you for our physical meeting, which is being held after a span of 2 years because of the unprecedented natural calamity that is COVID-19. I know we have been interacting on the digital media and online on various platforms, be it on the COVID or other gastroenterology and hepatobiliary disorders. But it was high time that we met in physical presence with each other. So I'm so glad to see all our own colleagues, including the younger people from the younger generation who have come here to attend this academic feast. The aim of our meeting has always have been to pass on the current knowledge of the state of art practice of various diseases of the gastrointestinal tract and hepatobiliary and diseases, as well as the endoscopic procedures. Since our focus is to take away this important carry home messages, because we believe that unless whatever has been discovered by the scientists, whatever has been proved to be of utility in double blind randomized trials, it should be, unless it is passed on to the generations of the hepatologists and gastroenterologists who are practicing, rest all is a futile exercise. So with that endeavor, we have been conducting these endoscopic and hepatobiliary clinics as well as the workshops in an effort to keep you updated with the present state of knowledge. I am thankful to all the delegates who have come to participate, and we look forward to their active participation. I'm also thankful to the seasoned faculty who have taken their precious time out of their busy schedule to update us about the recent trends in the common day-to-day gastroenterology and hepatobiliary topics. With that, I'll hand over the mic back to the organizers.
Thank you, sir. For the first session on luminal gastroenterology, can I please invite Dr. Anup Saraya and Dr. C.C. Chaubal to please moderate this session. I would also like to invite our chairpersons, Dr. Naveen TMU, Dr. Rakesh Kanchan, Dr. Barun Shresht, and Dr. Arun Kanduri to please chair this session. So please invite the speaker.
I welcome you all in this session, the first session, inaugural session. And the first speaker is Dr. Rupa Banerjee from Asian Institute, Hyderabad. And she'll be speaking on what is new in human GI microbiome. Does simple stool examination predict the future disease? So over to Dr. Rupa.
First and foremost, what Dr. Anil Arora said, it's really wonderful to be in person for a meeting. And I must thank Dr. Arora and the organizing committee for inviting me. The topic was, does a stool examination predict disease and what is new in gut microbiome? And I thought that would be just one slide. We still don't have one word answer that this is the predictor. So what we'll discuss, of course, is recent advances in the gut microbiome, what is new, and what is looming in the future. We know that why are we so late in discussing microbiome? Way back, Joshua Lederberg actually said that the ecological community of commensal, symbiotic, and pathogenic microorganisms that literally share our body space have all been all but ignored as determinants of health and disease. Yes, we thought we were we and ignored our ecosystem. I don't think I am I together with my gut microbiome. We are more bacteria than human actually. An healthy adult harbors 100 trillion bacteria in the gut alone. This is 10 times the number of human cells we possess. Interestingly, humans possess 23,000 genes. Microbiome contributes 3,300,000. So the communal gut microbiome, microbial genome is 150 times larger than the human genome. So it is the ideal environment that we looked for, harmony between man and microbiome. But we changed. This is what God gave us, and this is what happened. We became known for our bad air days. In Asia, we got fat. So what is happening? And now the focus is on the microbiome because there is an epidemiologic transition with increasing non-communicable diseases. Infectious diseases are coming down. India and the emerging economies are seeing the non-communicable diseases. And why is this happening? Because of all the lifestyle changes, migration, diet. We've heard about these terms, industrialization or westernization, as we can call it. But if you put it all under one umbrella, what is happening? It is the microbiota. So it is the microbiotal changes that is perhaps responsible for this increase in non-communicable disease. So the focus area becomes modification of the microbiome. The last decade has seen a rising interest. We are studying more. And how is this possible? Because we have been able to do a targeted 16S RNA gene sequencing. We have identified 4 major phyla: the firmicutes, the bacteroidetes, the actinobacteria, and the proteobacteria. Once we identify that, then the balance between this gives us some answer. We have the methods to study the microbiome now. If you see which microbes are there, the nucleic acids, we have the ssRNA approaches. What are the microbes doing? The RNA, metatranscriptomics, proteins, metaproteomics, metabolites, metabolomics, DNA, the metagenomics. So all these complex names are available. They're available easily. With advances, we can study them. So what are the factors affecting the gut microbiome? Actually, since birth, it's the genetics, birth route, geography, hygiene, stress, everything across a person's life is affecting the gut microbiome. When there is a perturbation, there is alteration, there is dysbiosis, there can be infectious diseases, metabolic diseases, and inflammatory disorders. So dysbiosis and disease can happen in 2 places. And now, in fact, they say that your mental health is related to your gut microbiome. Your happiness, your romantic features, today someone was telling me, is all being linked to the microbiome. But for the purpose today, we're going to look at the gut microbiota local influence on inflammatory bowel disease, irritable bowel syndrome, GI cancers, and so on. So there is now the opportune time, because all this technology is available, to move from bench to the bedside. Today, we'll discuss microbial alterations and clinical applications. Microbial alterations in obesity, the dilemmas of using antibiotics, should we not, what is happening, the clinical applications in inflammatory bowel disease, and of course, microbiome-based dietary alterations. So if you see obesity and microbiome, and I just put this one slide up because there are n number of studies which have now shown, without going into the complex names of the phyla, that there is a distinct difference between the obese and the non-obese in their microbial alteration. Interestingly, what has happened is, this is a very interesting study, that they randomized adults with obesity who were at high risk for development of diabetes to either oral fecal transplant capsules from healthy lean donors or placebo capsules for 6 weeks. So those who received fecal transplantation from lean donors were found to have a better gut microbiome. These are early studies, small studies, but this shows that obesity can be perhaps tackled by altering the gut microbiome. In fact, in the US, interestingly, there was a lawsuit filed for a lady who grew obese after fecal transplantation. She said that because you gave me the stool of an obese person, I was lean earlier, I have got obese now. So the world is changing. Coming on to antibiotics, and this is important. Antibiotics are fundamental life-saving modalities, but can also cause harm because of damage to the gut microbiome. The balance between the overuse of antimicrobials and the clinical need in these situations is often difficult to delineate. So in India, the antibiotic usage, we are one of the highest users of antibiotics in the world. But there are things that we don't know. We don't know what happens. What happens to the gut microbiome? Should we use? Should we not? How long should we use? When will the microbiota come back to its normal? I'm not reading through this list, but now we have characterized which antibiotic disturbs which fecal microbiota, which remains stable. And this, again, there has been numerous studies. This is just one compilation list. The relevant questions for us in clinical practice, as we discussed today: how do they impact the microbiome? Should we use probiotics with antibiotics? This is often used in general practice. So recovery of the gut microbiota of healthy adults following antibiotic exposure. So what was found is the gut microbiota. This was a study of 12 healthy men over a 6-month period following a 4-day intervention of a cocktail of high-grade antibiotics. What happened was the gut microbiota of the subjects recovered to near baseline within 1.5 months. 9 common species which were present in all subjects before the treatment remained undetectable. So every antibiotic that is being used, you are actually eliminating a tribe from your gut. So use of antibiotics definitely needs to be controlled. So gut microbial diversity recovers after an antibiotic intervention. However, some species may be lost forever. Gut microbiota remembered the resistance, and that drug resistance can spread on to the other bacteria in your ecosystem. So antibiotic resistance genes are transferred within the gut microbiome. So these may sound simple, but these are the factors that are impacting and autoimmune diseases is developing, and that is the link that we are seeing. Should you take probiotics with antibiotics? The answer to this question is not as black and white as we once thought. There are, of course, the pros of taking probiotics with antibiotics. They replace healthy gut bacteria, enhance immune function. This is what we already knew. Reduce duration of diarrhea, and that's what is being propagated, reduce C. diff associated diarrhea. But today, there are cons also which are being discussed. There is this delay in restoration of the natural gut microbiome. There is the theoretical concerns about fungemia and bacterial sepsis. More studies, of course, are needed, but we must remember that resistance within the gut microbiota is part of the genes as well. And this is a very important, these are the tribals, and you can see the small hamlet in the Brazilian forests. They have a huge diversity of their gut microbiota. That is a question of study across. These are the Yanomami tribals. But despite their isolation, tribal members have shown resistance to various antibiotic drugs, suggesting that resistance is not new. They had 60 unique genes that could protect their gut bacteria from the harmful effects or whatever the good effects of the antibiotics. So the next question regarding antibiotics. So you see, this is a fluid area. And as I said, there is no one word answer, but the trends indicate we need to be careful. Eradication of Helicobacter pylori infection, again, the same dilemma. There have been concerns of the emergence of antibiotic resistance, the perturbation of gut microbiota, development of metabolic syndrome after H. pylori eradication. But this was one large study of more than 1,000 adult patients given eradication therapy. And then their 16S RNA was done, sequencing was done, and assessed for long-term outcomes. For us, it shows that there was minimal disruption of the microbiota, no effect on antibiotic resistance of E. coli, and some positive effects on metabolic parameters. So results are indicating a long-term safety of H. pylori eradication therapy, and this is one of the largest studies. From microbiota research, we come to its clinical applications in inflammatory bowel disease. If you see here, and I work with inflammatory bowel disease, so in numerous patients, when we are analyzing the microbiome, we are actually finding the Roseburia and the Faecalibacterium prosynethziae, the butyrate producers, in much lesser numbers than the healthy adults. So it is assumed that prebiotics, probiotics will change all this. And we see so many IBD patients on so much of probiotics, and these are costly as well. So probiotic has become a branded supplement, a panacea. We are not going to the natural thing. People are just going on and having probiotics in various forms. So between probiotics and prebiotics, there is a hype versus there is a reality. Because if you analyze studies, you will find that probiotics in Crohn's disease, there is an unclear benefit. For ulcerative colitis, it is the E. coli Nisle or the VSL3 as we call it, some clinical benefit reported in some studies. At the same time, this is the early warning signals. So indiscriminate use of probiotics may not be warranted because they said that post-antibiotic gut mucosal microbiome reconstitution is impaired by probiotics and improved by autologous fecal microbial transplantation. And when it comes in a journal like Cell, it does have some value. Now is the turn of, can we predict response to standardized therapies for ulcerative colitis? We know children with ulcerative colitis have moderate to severe disease course, high corticosteroid dependency, and refractory disease. Up to 25% of children have a colectomy within 5 years. So this was a multi-center study of 428 treatment-naive children with ulcerative colitis, and their rectal and fecal microbiome was profiled using 16S RNA amplicon. So what happened? Before treatment, an association with clinical outcomes was conducted to develop predictive models of disease. What was found is those with relative abundance of pneumococci and Cittarella, there was higher corticosteroid-free remission. Those who had oscillospora, this was the group which did not respond to corticosteroids and actually needed anti-TNFs. So the microbial profiling could actually predict the response to treatment. So that is going to be the next gen of treatment, personalized medicine. Your microbiota is like this. You're unlikely to respond to steroids. It will respond to this biologic or that biologic. When we have so many drugs, I think this is what is coming. And as you can see, these are large studies showing the same. What's new here? Microbial factors in the gut could improve prediction of response to initial therapy, identify novel therapeutic targets, and help develop personalized approaches to improve outcomes. Similarly, mucosal healing and bacterial composition after enteral nutrition. So children were given steroids or given exclusive enteral nutrition, and their gut bacteria was followed up. What was found again is that with exclusive enteral nutrition, the one name that we should now remember, Faecalibacterium prausnitzii, was higher than when used of corticosteroids. And what was the results here? At 8 weeks, clinical remission was almost equal in both groups, but mucosal healing significantly higher in those on the exclusive enteral nutrition group. So in our hospital, we've just started our microbiome research lab. And what we are finding is quite interesting. You know, there is a distinct difference between the microbiome of the vegetarian population to the non-vegetarian populations. We've checked in more than 200 patients, and the pattern is consistent. We find that the short chain fatty acid producing bacteria, again, there is this difference between vegetarian, non-vegetarian, and we know that short chain fatty acids producing bacteria are relatively lower when dietary fiber is low. And this again correlates with Crohn's disease. So people with Crohn's disease are having lesser amount of this short chain fatty acid production. So when we see, even with the Indian diet, this is very classical. And I thought I'd share one set of reports. This was monozygotic twins with IBD who had come in. And what we found, absolutely the same for the twins. Developed in 2019, 2021, colonoscopy pictures almost the same, ileum and the ileocecal region. There is a distinct alteration of gut microbiome even when we compared it with their parents. And if you see here where the twins are, and if the green is all the normal healthy population which we compared it with, the parents lie there. So perhaps it is not an altered microbiome causing IBD. IBD also can alter the gut microbiome. So these are solutions that we have to look into, but the results, and you can see the Sarkos plot, there are some species which are completely absent in the twins. Similarly, they stay in the same house, same environment, same food, yet a different microbial system. We checked between the probiotic bacteria, significantly lower in the twins, if you see. So these are interesting results, good to discuss, but there is a lot of work that need to be changed. Distinct species are seen in those with IBD and those who are not. And finally, I thought we should touch on this area where we're working on right now. We know American Journal of Gastroenterology has said food as medicine, diet as a microbiome-centered therapy for IBD. There have been numerous studies. I'll just go past this, that diet-dependent changes in the microbiota, and numerous diets are now being developed. And they are seeing that, in this study, majority of patients treated for at least 8 weeks with as minimum as 50% dietary compliance reported a dramatic decrease in disease severity. So there are gene markers coming in. There are changes in microbiome that we are seeing, and maybe we can design the perfect diet. Dietary therapy based on microbiome is the future. We know that Mediterranean diet is there. We are conducting some studies on the Mediterranean diet, designing a Indianized diet.
Dr. Rupa, can you sum up in next 1
Yes.
minute? Thanks.
So what we are seeing is that there are changes which can be brought about by dietary intervention. It is indeed time to move from bench to bedside. Current therapeutic options are just this much: indirect modulation by diets, prebiotics, and antibiotics. This is the future perspective. Next generation live biotherapeutics, a single strain, what is needed, we can give genetically manipulated strains. And finally, food is perhaps your best medicine. We will have dietary therapy for most of the diseases. We are designing such diets. Globally, there is a lot of attention, and I'm sure, as Dr. Anil Arora's original question was, we will be able to define disease based on the microbiome. This is our team. I would like to invite you shortly for the Endocon and in April for the IBD Summit. Thank you.
Thank you, Rupa. Now, for any few quick questions, would Chairperson like to ask something?
In 2000, in our country, we hardly used to see IBD cases. In practice, when we used to see about, mesalamine, which was not there initially to start with, and 5-ASA was there, and all these things were being coming up. What has happened over the last 2 decades, which in fact has caused so much of microbiome to be studied about, and even after studying, are we really coming to some end somewhere? Is the diet which we used to take before 90s was good? Or what has happened today that we talk about the Mediterranean diet, the continental diet, and other things? The malignancies, the pictures which we see in the intestines are also the same. And now the latest thing which people are also doing is about the intestinal ultrasound, which you basically see and how to correlate between the diet, the IBD, the things, and other. Can you just highlight on?
I think this is a very good question. It is true that IBD is on the rise in this part of the world. Initially, people, and we thought that because there was increased availability of colonoscopies, but now that has covered. In fact, we are conducting rural studies. We are going into the villages and identifying that even in the villages, there is IBD. So we are trying to identify the environmental factors. What we find has changed is even in the villages, there are small shops selling soft drinks and Lay's chips. And the interesting photographs, that's what. Numerous studies have shown it's not actually the diet, it is the processed foods and the preservatives, the emulsifiers. So the butter looks very nice because there's emulsifier added to it. So it is those things which are perhaps responsible. Migrant studies have shown that Indians, we have the genes for IBD because IBD in the US is higher in Indians than in the US people staying in the US. So we have it. It is going to be an epidemic. We need prevention strategies, and that's why the focus is on dietary therapies to alter the microbiome. Maybe it happens via the microbiome.
Only 2 short questions. One is we have been talking about pre and probiotics and prebiotics. What about the postbiotics? What are these? I mean, people are, there's something they call now that even the postbiotics are going to come now. The other question is, see, we use so much antibiotics here. What do you think? You have a big center running in Hyderabad. What difference do you see regarding the incidence of C. difficile infection, West versus India? In spite of so much of antibiotic pressure, I still feel that incidence of C. difficile colitis, etc., is much less in India compared to what they have in West. Why is it so?
This why is difficult to answer. We see less, but my experience has been, this is strange that, when we are doing clinical trials and we are sending the samples to a centralized lab, Sometimes where we don't detect it here, it is being detected. However, India is different. Our disease is different. We published recently that, we don't need the 4.8 grams of mesalamine for our IBD. We need much lesser doses of azathioprine. So our disease pattern, prevalence of other diseases, infectious diseases may cut the Clostridium difficile infection over here. So it is an enigma, and I think it is time that we should start thinking about Asia, South Asia as a different community, not follow the Western guidelines absolutely blindly. It's not because it's good or bad, but so far we lacked in doing studies together. But now we can do collaborative studies from this region and have our own guidelines.
Dr. Kanduri, you have a question.
No, I just wanted to know how far are we from in India? You have established a lab. How far are we from studying actually the gut bacteria clinically, or maybe in clinical practice?
I
And
think
do we
it's-
have some center where we can sort of?
Yes,
get
I
these
think
done?
you can send to our center itself. We can analyze the bacteria. We can identify at least, we have a list of pathogenic strains, if not anything which we can identify. We can clearly seeing dysbiosis in patients. We have patients on probiotics who have only probiotic bacteria in their gut. There is no other bacteria. So once technology becomes available, it's no stopping. It's just that we have to study, we have to work together and then see how best. We're still at the brink roads, but I think gut microbiome analysis is soon going to be very, very available.
Last quick question.
I just want to know, now there is a increasing use of antibiotic. Previously, we never used to use that antibiotic. Now every other person is using antibiotic, that too over the counter. So it is affecting the gut microbiome.
You are absolutely right. It is affecting the gut microbiome, and that's why out of so many things for the talk, I selected antibiotics as one of them, because we are using it sometimes indiscriminately as well. So yes, it is impacting the gut microbiome. We have just done some studies. We presented it at DDW this year of screening colonoscopies, and in that we found that patients with IBD have a higher incidence of antibiotic usage at less than 6 months of age, highly significant, and significant at less than 1 year of age.
And can it cause
So
mutation in the genes?
antibiotic usage in early childhood is a strong no, unless absolutely justified. For any cough, cold, the use of over-the-counter antibiotics is strongly to be avoided.
Can it cause mutation in the genes? And
They are
maybe some
saying that
changes in
if
the
drug
makeup?
resistance develop,
I think we are running short of time.
it will pass on to the other gut bacteria. So some resistome does stay back.
Thank you, Rupa, for excellent
Thank you.
lecture.
Thank you. Thank you.
Thank you.
Dr. Rupa, can we invite you for a picture, please? The chairpersons and the moderators request you for a picture. For the next session, I'm going to be inviting Dr. A.C. Anand and Dr. P.K. Agarwal to please moderate the session. Can I also invite Dr. Nandu P. Silwal, Dr. Mohan Bhushal, Dr. Dilip Sharma, Dr. R.L. Bhatt to please chair this session. Thank you, chairpersons. Thank you, speaker. Thank you, moderators.
I have great pleasure in inviting Dr. Vineet Ahuja. Is he here? To give a talk on biologics for IBD patients in India, which, when, and for whom. He is not only the last word on IBD in India, but also one of the best orators I have heard. And his talks I always find very riveting. Dr. Vineet Ahuja.
Thank you very much, sir. No, thank you very much, sir. You humble me truly, and thank you, Dr. Arora, for this meeting. And as usual, on a Friday evening, right to the first day, you see the hall is full. All credit to him. So I'm supposed to talk about biologics for IBD patients in India, which, when, and for whom. So if you look at it today, then we find that so if you look at it, if the choices we have today, like just 15 years back, we had only infliximab. That was the best choice we had. And today, if you look at it, we have plenty of choices. We not only have infliximab, we have its biosimilar, adalimumab, we have its biosimilar, vedolizumab is there. I've put up ustekinumab also out there. Ustekinumab is IL-12, IL-23 inhibitor. It should come to India within 6 months or 1 year. So I thought that I'll put it also out here. Tofacitinib is already there as an oral small molecule, and surgery still remains a strong bastion. So the question is that today you have too many choices. Does this plethora of choices, so many choices, does it make you very happy? Or there's a paradox of choice that when you have too many things, you really don't know what to do. So let's explore them with the help of a few case illustrations. First thing is that when is the right time to start biologics? All of us feel that, okay, if the disease is a little bit of flare, maybe biologics is something which is a magic pill. Immediately it will take care of the disease and everything would be all right. So if you look at patients who have been given anti-TNF, we find that patients of Crohn's disease, if they are started on biologics early in the course of disease, let's say within 2 years or something, there it changes the natural course of the disease. They have lower healthcare utilizations and all subsequently. Is the same effect seen when we give biologics early on in the course of disease in ulcerative colitis? No, that seems not to be true. Ulcerative colitis patients do not exhibit the same kind of benefit. That is what this very recent study showed. What about vedolizumab? Would vedolizumab change the scenario? No, it doesn't seem so. But yes, at the same time, vedolizumab confirms the same signal which you are getting for anti-TNF. For Crohn's disease, again, if vedolizumab is given early on in the course of the disease, it leads on to a more complete response. Whereas in ulcerative colitis, the disease duration is not associated with the response to vedolizumab. In other words, the take-home message out here is that if you're really keen to start biologics, maybe if you start biologics early in the course of disease for Crohn's disease, you would be correct. Whereas in ulcerative colitis, unless and until you have given azathioprine, particularly in a country like India, I don't think it would be prudent to start biologics till the end until you have exhausted that option. So case 122, these are all real cases, 22-year-old girl who came with 2 months history of loose stools, bleeding rectum, crampy abdominal pain, weight loss, diagnosed to have typical ulcerative colitis. She underwent the sigmoidoscopy, which showed some large ulcers, pseudopolyps and all. A CT abdomen was also done because she had very large ulcers and some of people felt that possibly there's a possibility of a Crohn's disease. X-ray showed a lead pipe colon. There was no megacolon or something like that. Colonoscopy showed that, okay, there were deep ulcers out there. The patient was diagnosed as a case of acute severe ulcerative colitis, started on intravenous steroids. Antibiotics were added in this stage because there was a possibility that there was a lot of leukocytosis and all. We give exclusive enteral nutrition to these patients in addition because it has been seen, at least at our center in a study, that exclusive enteral nutrition increases the steroid responsive rate, and thromboprophylaxis is also given. On day 3, the patient was assessed. It was seen that the response was not very good. By that time, the CMV titers also came up. In the real-time PCR was done in the biopsy, which showed that CMV was positive. The patient was started on IV ganciclovir. By day 6 and all subsequently, the response was not so good. The patient was not doing so well. So the question is that in a case of acute severe ulcerative colitis, not responding to IV steroids, which of the next therapeutic option would you suggest? Like in this case, like you have infliximab, you have cyclosporin, you have vedolizumab, you have surgery, you have tofacitinib. We have plenty of choices today. So what do you think would be the best choice? So here I put up the algorithm. ASUC not responding to IV steroids, These are the various choices we have. And I've also put up actually rich and poor in terms of tofacitinib is something which the poor can also afford. Whereas for Inflixi, Adali, vedolizumab, obviously you need to have some financial muscle. And what you realize out here in this setting, particularly acute severe ulcerative colitis, it's best to use anti-TNFs. Amongst anti-TNFs, best to use infliximab. Infliximab would be equivalent to cyclosporin. That would be equivalent to surgery. Now there's a new kid on the block that is tofacitinib, which you all know is a JAK kinase inhibitor. Tofacitinib is very good in this setting, especially if a patient cannot afford infliximab or if there has been an infliximab failure. The only thing is that if you're going to give tofacitinib in this setting, the dose should be 10 milligram TDS for 3 days, and thereafter you reduce the dose to 10 milligram twice a day for 2 months. That is the induction dosing. Case 2. It's around, I would say, 25, 30, 70-year-old gentleman who presented somewhere in 1975 with 30 years of, he had, at that time his age was 30 years, he had bloody diarrhea for 1 year with urgency, diagnosed as ulcerative colitis, initially managed at PJ Chandigarh, where he was in clinical remission on sulfasalazine, and thereafter he was moved on to 5-ASA, and he seemed to be doing well. But from 2011, suddenly he started having multiple relapses. And thereafter he was put on azathioprine. With azathioprine also, he had multiple relapses, so he was put on steroid courses, and subsequently the patient really was not doing well in terms of having a relapsing course on and off. He had anemia, he required hypoalbuminemia, anorexia, weight loss of 20 kgs and all with a high FCP. So the question was what to do next. Out here, immediately what would you do? Would you do a screening colonoscopy for colorectal cancer? Would you give infliximab? Would you give vedolizumab? Would you do surgery? Or ustekinumab, once it is available, would you like that? A patient who has had ulcerative colitis for 30 years and subsequently he has been on azathioprine, still continues to have relapses out here. So the answer out here would be that the first thing you should do before thinking of biologics out here is screen the patient for colorectal cancer. Even in India, it has been seen that patients of ulcerative colitis, once they have a disease duration of 10 years or more, they tend to have a frequency to develop colorectal cancer, and that frequency really moves on to 20% once they have a third decade of disease. So they should be screened for colorectal cancer. Once you have screened the patient for colorectal cancer and found that there is no malignancy which is causing deterioration of the disease, then the next question is the patient, you have exhausted the available options. You have given steroids, you have given azathioprine. What would you do next? Would you like infliximab, vedolizumab, surgery, ustekinumab, tofacitinib? The choices are available for you. Again, the same kind of setting. So here you would see that in a steroid-dependent ulcerative colitis, elderly patient who may be prone to infection or who has had a recent history of malignancy, vedolizumab would be a much safer choice out here. In fact, the safety signal for ustekinumab is also coming out to be very good. It would be as good as a safety signal for vedolizumab. So this patient was started on vedolizumab, given 3 doses of vedolizumab, went into clinical remission, had a very good response. Fecal calprotectin also normalized, but after 4 doses of vedolizumab, surprisingly, the patient had a relapse. Generally with vedolizumab, initial induction is slow, but once the patient maintains on vedolizumab, the chances are the patient would do well. But here what was seen was that the patient had a relapse. So the options before were, do we go back to anti-TNFs? Ask the 70-year-old gentleman to go in for colectomy, go in for tofacitinib, or if you had ustekinumab available, what would you like to do in this setting out here? The patient was started on tofacitinib. He didn't want to go on anti-TNFs. That's why he never went on anti-TNFs in the previous decade, because he was always afraid of the risk of infection. So he was started on tofacitinib this time. By that time it was available. 10 milligram twice daily was given for 8 weeks, and subsequently a maintenance dose was given. He went into clinical remission, normal FCP, HB 13.2, albumin normal, and the patient is doing well right now with tofacitinib 5 milligram daily. So the question is that obviously tofacitinib we discussed about the safety signals and found that vedolizumab was the safest drug and ustekinumab almost as safe. Infliximab, very effective drug, but yes, there are chances of either infections or reactivation of other things. So the question out here is the risk of infection as well as TB reactivation is least with which of the following agents: infliximab, adalimumab, ustekinumab, and tofacitinib. Well, it seems that tofacitinib also has a chance of TB reactivation. So if you're going to put a patient on tofacitinib, you would like to screen them for TB the way you screen any patient when you put them on anti-TNF. What about ustekinumab and all? When the risk of infection was compared for ustekinumab and tofacitinib, it was seen that ustekinumab was associated with a significantly lower risk of infection. The risk of infection was similar for tofacitinib and anti-TNF. Both of them have a higher risk of infection. What about ustekinumab versus vedolizumab? There's a very recent meta-analysis which has come up, which showed that in Crohn's disease, there was a much lower risk of serious infection with ustekinumab, whereas for ulcerative colitis, there seems to be a knowledge gap. For vedolizumab, surprisingly, there was no difference for Crohn's disease for anti-TNFs versus vedolizumab, whereas in ulcerative colitis, there was a lower risk of serious infection with vedolizumab. And for ustekinumab versus vedolizumab, it was seen that in Crohn's disease, ustekinumab fared better when it came to the lower risk of serious infection. In other words, to summarize, two safe drugs would be vedolizumab and ustekinumab. Whereas, so particularly in a setting where you have an elderly patient or a risk of serious infection, there you can consider these drugs. Now, anti-TNF we know leads to TB reactivation. In India, it has been seen that around 10% rate of TB reactivation. So how are you going to avoid it? Is it possible to avoid it? So this study suggested that if the screening is very stringent, normally how we screen is either do a MON2 or do a TST or just do a chest X-ray. And if you find evidence of any latent TB, you start the patient on prophylaxis. However, if you do a very stringent screening, that is you do TST, you do IGRA, do both the tests, and do a CT chest rather than a chest X-ray. You may do a HRCT, not do a contrast CT, but do a CT chest. Look for past history of TB. And if any one of them is positive, particularly the past history of TB, or if the patient is showing, the CT chest is showing old healed TB, put the patient on chemoprophylaxis. It seems to work, as it was seen that patients who were earlier, who were being followed up, there the risk of TB is around 8 to 10%, whereas subsequently when this strategy was applied in 59 patients, subsequently we had only one patient who developed TB, showing the risk reduction from 17% to 1.7%. So this is a very simple strategy by which your fear of using anti-TNF, particularly with respect to TB reactivation, can be mitigated. So steroid-dependent ulcerative colitis patient, elderly, prone to infection, these are the two choices you have. Now let me come to the next question. Case, 19-year-old girl who presented with fever, jaundice, pruritus, bloody diarrhea. She had ulcerative colitis. Subsequently, it was also seen that ANA was mildly positive, alkaline phosphatase a little bit raised. So a biopsy was done, MRCP was done, which was normal. A biopsy was done, which showed cirrhosis, autoimmune hepatitis, bile duct injury. So AIH with PSC overlap. Started on steroids, azathioprine added, patient kept on relapsing. Sometimes ulcerative colitis would relapse, sometimes a liver disease would relapse. So it was a question of what to do like. So thereafter, the patient also developed ascites. She was put on diuretics. She had a CTP score of 8 with a MELD of 11. So tacrolimus was added because azathioprine was not working. So once you're given steroids, you've given tacrolimus, you have given azathioprine, this is a case of autoimmune hepatitis with ulcerative colitis. The question out here would be, what are you going to do? And this patient is whether you can put such a patient on anti-TNF inhibitor or not. Or you are going to use a biological like vedolizumab. Do you think that would be better? Or ustekinumab can be used, or straight away the patient goes for colectomy followed by liver transplantation. Well, out here we started the patient on infliximab and see the trend of liver function tests. The liver function tests gradually settle down. There are case reports, which are case series available of infliximab being used in refractory autoimmune hepatitis. So here infliximab fitted the bill by managing both these diseases. So although infliximab has also been associated with drug-induced lupus, but yet at the same time, remember that in a case of autoimmune hepatitis, vedolizumab may not act so well. Infliximab would be better because there seems to be some kind of data which is available for that. There is study available for vedolizumab also, this study, but however, this study showed ambiguous results where there was a 20% rise in alkaline phosphatase and 20% patients who benefited in this study, clearly ambiguous results. So the message out here is any patient of ulcerative colitis who has extraintestinal manifestations, Angst-Pound or something like that, or pyoderma gangrenosum, there in that case, if you have the choice of all these agents, then vedolizumab would not help in this kind of setting. Here, vedolizumab, in fact, has been associated with increase in arthralgias and all. Surgery would not help. It would not take care of the EIMs. What would help is infliximab or adalimumab, even tofacitinib. Tofacitinib has been shown to be useful in patients with gastrointestinal manifestations, and same kind of signal seems to be emerging for ustekinumab. Another case, 32-year-old lady diagnosed with ulcerative colitis in 2015, started on steroids, azathioprine. Thereafter, she was intolerant, did not do well. So the question is put on anti-TNF. So started on infliximab in 2017. She was for 2 years, she did well on infliximab, went into remission, decided to stop infliximab, had a relapse. So the question out here is that she had a relapse. So should we have done something in addition to infliximab? Would you like to add azathioprine? And if you're going to give an azathioprine, are you going to give it with infliximab, adalimumab, vedolizumab, and ustekinumab? Well, the answer out here is that with infliximab, definitely for 6 months to 1 year. Adalimumab maybe for 6 months, but with vedolizumab, you don't need to add azathioprine, methotrexate, anything which decreases the immunogenicity of the drug. This patient was put on vedolizumab subsequently. Even with vedolizumab, she was not doing well, and subsequently she was started on 2 biologicals. She did not want to go in for surgery. She was started on infliximab, and with infliximab and adalimumab, she seems to be doing well. So here the question is, okay, obviously, like this is like something like Agnipath, like the scheme which was launched out there. Like Agnipath, the whole thing was that ultimately 25% of people are going to make it. So what relevance has it got out here? That when it comes to biologics, again, when you start biologics, at the end of 1 year, or at the end of 2-3 years, you realize that only 25% of the patients are being maintained on biologics. Some of them would have had a primary loss of response. Some of them would have adverse events. Some of them would have a secondary loss of response. So ultimately, it's only a fraction of people who make it. So the question out here is, how do you enhance the response in the Indian setting? How do you decide pre-hand that, okay, I'm putting a patient on biological, can I improve the response or not? What are the predictors of the success of biological therapy? And there have been a lot of disease-related factors like longer duration of disease or initial non-response and all, which have been thought to be non-predictors. But out here in our cohort of 186 patients, when we looked at what is a major predictor of non-response, that is we found was serum albumin, both for primary non-response, that is initial non-response, and secondary loss of response. That is, the patient responds initially, subsequently there's a loss of response. So it was seen that for Crohn's disease, serum albumin was a very important factor. For ulcerative colitis, again, serum albumin was a very important factor. We looked at certain molecular markers also, but they are not possible in clinical setting. In a clinical setting, just serum albumin by itself should help you in guiding therapy. So coming back to that case, can you add, so how do you improve the response? Look at serum albumin before starting it, see if you can improve it. If not, then give biologicals and decide how do you change the dosing. Can you add one biological to another biological? There is no RCT available on it. This is the sum total of all the data which is available in form of various kind of combinations which have been used, but these are used only in refractory cases, cases which are not responding at all. And so what kind of combination you can use which are safe, and a combination which you will not like to use. And again, these patients should be best treated at tertiary centers because the risk of side effects and adverse events would be much more. So anchor agent anti-TNF additive drug can be vedolizumab or ustekinumab. Vedolizumab you can combine with tofacitinib, or as I told you, anti-TNF inhibitors. Ustekinumab, again, you can combine with vedolizumab or tofacitinib. So you can make all these combinations, except try not to add tofacitinib to anti-TNF inhibitor. The moment you make this kind of combination, the risk of serious infection increases substantially, and that is something you would like to be careful of. IBD with pregnancy, which biological or oral small molecule you can use? Tofacitinib is totally out here, because out here tofacitinib cannot be used. Infliximab, adalimumab has plenty of data. Surgery you would not like to use in such a kind of setting. Vedolizumab and ustekinumab data is emerging. There seems to be reasonable data, but I would say data is still emerging out here. Just 2 slides on Crohn's disease. Crohn's disease, which biological would be the best? Tofacitinib is out. Tofacitinib does not work in Crohn's disease. Leave aside anecdotal cases or case series or real world evidence. It is like filgotinib or upadacitinib, that data is going to come out where it would be useful in Crohn's disease. So here in such a kind of setting where it is steroid-dependent Crohn's disease, you can use infliximab as well as adalimumab. I showed you in ulcerative colitis, infliximab possibly superior to adalimumab. Here you can use infliximab or adalimumab, any one of them as first choices because they seem to act equally well. Vedolizumab is also a good choice, but remember in a stricturing disease, fistulizing disease, where the quantum of inflammation is very high, vedolizumab may not act so well as anti-TNF therapy and all. If the patient has a B2, B3 disease, again, infliximab or adalimumab, and surgery is another option which should be tried. Vedolizumab can be used if none of them are working. So this is my final slide that we talk about biologicals, and all of us initially felt that, okay, anti-TNF therapy is going to change the natural course of the disease and all. And not only that, as physicians, and particularly as I would say younger physicians, when you start biologicals, you feel that this patient is going to do spectacularly well. And the patient also has that kind of expectations. But remember, there may be some truth in it, but not complete truth. IBD is like this. IBD is like Ravan. Why like Ravan? What you're doing with anti-TNF, you're just beheading one head. Tofacitinib, you're taking off another head. IL-23, you're taking off third head. IL-12-23, you're taking off another head. But what are the heads? The heads are sprouting back. They sprout back one after the another. But whatever drugs you're using out here, you still do not have what is known as a Rambam in terms of curing the disease. What you're doing is controlling inflammation. And remember that. That's one of the most important messages, which I believe we should keep in mind the moment we start prescribing biologics, so that then and only then, I feel we can treat the patient holistically. This is just a part of the story. This is not the end of the story. Biologics. Thank you so much.
Thank you very much. That was an excellent talk. And very clearly, he has described all the situations and what is the choice of biologics and how to choose them. The talk is now open for questions and comments. First the audience, then the chairpersons, and then the moderators.
Thank you, Vineet, for excellent presentation as always. My question is, you are the same human being who has obnoxious diet or obnoxious bacteria, microbiome. One of them develops a Crohn's, another an ulcerative colitis, same diet, same environment. Is it something to do with the genes or the microbiota or the diet? And second question is, if you're looking for a Ramban, why is it that we are so averse to doing surgery in patients who have, say, refractory ulcerative colitis after two doses of steroids or one dose of infliximab? Why is it that we never talk of surgery in gastroenterology meeting?
So number one, there's clear-cut data, I would say, till now. Obviously, the data keeps on emerging that microbiome has not been shown to be cause of IBD. In fact, if I can extend myself till now, I do not find any data where microbiome has been shown to be cause of any other disease. The data which is available is in mice experiments, where it has been shown that probably it may be causing the disease. In humans, there is no such data. Yet at the same time, there is plenty of data from India, from our center, from CMC Vellore, which has shown very clearly that there is a lot of microbial perturbation which occurs in both patients with Crohn's disease, occurs in patients with ulcerative colitis, and also changes with the severity of the disease, mild disease, moderate disease, severe disease. So what it tells you that microbiome is an important player, right? So once it is an important player, if you change microbiome, it also changes the course of disease. We recently published a study on FMT with anti-inflammatory diet in patients with ulcerative colitis. And it was shown that it has been in mild to moderate ulcerative colitis, it has been effective in inducing remission and maintaining remission. It is just come out in gut. So it showed 7 sessions of FMT, and then they were given anti-inflammatory diet for subsequently the whole year. That anti-inflammatory diet was sufficient to maintain the response which was induced by FMT. But yet at the same time, none of these studies show that microbiome is the cause. So microbiome is an important player, genes remain an important player, aberrant immune aberration remains an important player. So the thing is that you can address any one of them for treating. And the second question was that surgery is so that is why in every slide I had a box for surgery. The problem with surgery is that for Crohn's disease, surgery is not curative, yet at the same time, it is very effective for terminal ileal disease, as the recent lyric trial showed. Number two, surgery takes away the disease burden, particularly in a enteric fistulizing Crohn's disease. The only thing is you have to give post-operative recurrence because disease invariably occurs. For ulcerative colitis, surgery is curative, but it's a three-step surgery. If it was like lap chole, everybody would have run for this surgery. Here, the patient is afraid of surgery, three-step surgery. The physician, as usual, doesn't want to send the patient for surgery many a times, and the surgeon is afraid of this surgery. This surgery requires a learning curve where if you are doing, let's say, 100 pouches or something like, then your results would be excellent. Otherwise, 20% of patients do have pouchitis. So surgery remains a very good option for ulcerative colitis, but again, it is dependent upon these factors.
Can we have a question from the mic at the back?
Sir, so many a times the patients are unaffording for biologics who are azathioprine refractory. Sir, what is your experience with oral tacrolimus in such patients?
That's an excellent drug. So in patients who are not responding to azathioprine, they cannot afford biologics at all. So tacrolimus is a very good drug. The only problem with tacrolimus is the long-term sustainability. We have some very good data from Dr. Puri's group. There was a thesis also where they tried tacrolimus, oral tacrolimus in moderately to severe ulcerative colitis, acute severe ulcerative colitis setting, and they showed the benefit. The problem with tacrolimus is the same as cyclosporin. Cyclosporin you give for 3 months, then you want to close it down. Why? Because you know that subsequently the relapse rate is going to be higher and on, or the infection rate would be higher. The same problem is with tacrolimus. That is what we do.
Dr. Chaubal?
Simple questions. As you talked about this tuberculosis and use of biologics, a person has acute severe ulcerative colitis where you want to start infliximab on this thing. He also has tuberculosis. What is your policy? Usually you give full course of anti-tuberculosis. I mean, infliximab are started under cover of that thing, or you prefer to go to cyclosporin and not give infliximab in that situation?
So if a patient has active tuberculosis, then obviously no point of starting in that setting anti-TNF.
Not even under cover of
No, at best would be surgery if the patient can undergo surgery. If the patient cannot undergo surgery, then maybe with ATT you may start. Cyclosporin would be a much better choice. If the patient has latent TB, latent TB is difficult to detect practically in acute severe ulcerative colitis patient setting. Why? Because the patient is on IV steroids. You do a MON2, obviously the result would be indeterminate. You do a TST, the result would be indeterminate. The patient is on 400 milligram hydrocortisone. So there, if you do a CT, if you find old evidence of COX, or if you want to be very safe in such a kind of setting, you can start INH prophylaxis along with biologicals. If the patient has TB, then best is to wait for 4 to 8 weeks of ATT before you start anti-TNF
or elective situation, not favorable. Another thing is your Sonic trials have shown a combination of infliximab and azathioprine. Why doesn't it work so well with tofacitinib and azathioprine given together?
So tofacitinib and azathioprine, till now the thing is that in terms of it will lead to so much of immunosuppression. That is what people feel, that in anti-TNF you're blocking one cytokine, that is TNF. With tofacitinib you're blocking multiple cytokines. Along with that, you have azathioprine, which is causing apoptosis right at the lymphocyte level. That is causing lymphopenia by itself. So as a result, it's a possibility which maybe in a future study may explore and find that it can be used. But as of now, one will have to be careful when using it. A lot of many patients are on tofa and azathioprine more because of the reason that the patient was on azathioprine not doing well, or infliximab not doing well, started on tofacitinib. So azathioprine is continued asset because people tend to forget to whether you have to close it or not. Otherwise, prospectively difficult to start both of them.
Yes, sir. Your question.
Vinith, excellent as usual. I want to know, you've been using biologicals for a long period, even in India, though, we started late compared to the world. What is your take on the malignancy part, the CRC? Have you seen any difference between top-down approach when you started biologicals early in the process? Has there been any observation on development of colorectal cancer?
So colorectal cancer, first thing is the awareness that colorectal cancer in India, where sporadic colorectal cancer is low incidence. Despite that, in IBD patients, the incidence seems to be similar as in Western countries. One. Secondly, the infliximab would decrease colorectal cancer only if it is given for a long period of time, because one of the driver for colorectal cancer is, since it is an inflammation proliferation malignancy paradigm. So obviously you control inflammation for a long period of time, which 5-ASA was also doing it, which azathioprine can also do it. So infliximab, if it would, or any biological, if it would have an effect, it would be in terms of decreasing inflammation. And if it is given for a sufficiently long period of time, then only you can do that. Otherwise, you are basically looking at lower hospitalization rates, lower colectomy rates, improvement in the quality of life. Paradoxically, anti-TNFs can give rise to malignancy, particularly in younger people. Azathioprine and anti-TNF combinations, or as such, anti-TNF may be predisposed. But in recent data from our center, which looked at azathioprine, around 1,000 patients on azathioprine, of which 250 perhaps of more than 5 years, 70, 80 patients more than 10 years, there was no case of lymphoma, showing that lymphoma can occur, but still the incidence may not be that high.
Any questions from the chairpersons?
Very nice. I was interested in your study of gut. Was it an observational study or a randomized study?
Randomized control trials.
And
Two arms.
what did you give to the controls?
We gave standard medical therapy, which was optimized in the sense that if they were mild to moderate ulcerative colitis. So 5-ASA, if they were there, the dose was optimized. If they were not on topical therapy was added.
But then such a study can't be blinded.
No, it was an unblinded. It was an
after that.
open label RCT. And here we didn't do a sham control trial for the simple reason that it would have caused, we thought, inconvenience to the patient.
You can have more discussion after the talk. Yes, sir.
My question is there any role of biologics in PSC when patient has already undergone colectomy?
So if a patient PSC as it is, none of the biologicals have shown to be effective. PSC, although it's an extrinsic manifestation of IBD, yet at the same time, none of the immune altering drugs, even like steroids, seem to change the course of PSC. So biologicals, they have no role in PSC. As I showed you in a case which was a AIH PSC overlap, there for autoimmune hepatitis, infliximab seek to help. Otherwise, the biologicals do not have any role. And the only thing is, once you do colectomy, early colectomy, the signal which has been seen is that chances of cholangiocarcinoma or chances of recurrence of PSC after liver transplantation decrease, surprisingly. That for PSC, you'll do liver transplantation. The recurrence chances are around 20%. However, if the patient has had a colectomy prior to that, then the chances of recurrence after liver transplantation will be little lower.
My co-chairperson has a question.
Sir, I've got 2, 3 things. Talk has been spoken lots about nowadays. And I think most of us are using tofacitinib, because it's cheap, easily available, and giving good results. How long can you use TOF, sir? Normally it is said 2 months or 3 months, what's it?
So the induction,
and I've seen a lot of relapse coming up once you stop it.
So induction dosing is for 2 months, 10 milligram BD. You can increase the induction dosing to 16 weeks if the patient is not really properly fully induced. Maintenance dose is 5 milligram BD, which in Octave studies was a 1 year. But however, we have data subsequently post-Octave, Octave, which showed, I think, 3 years or 4 years. And thereafter, we have data from 7 years from the rheumatological group, which shows that they have used for 7 years and they have found it to be fairly good enough, because the maximum toxicity occurs with the high dose of 10 milligram BD, that is herpes zoster reactivation or thromboembolism. So that is a crucial period. And that is why in acute severe ulcerative colitis, if you use for 10 milligram TDS, you should be very clear that thromboprophylaxis has to be given. Once it goes on to 5 milligram BD, then there may be side effects, but the dreaded side effects, the frequency goes down definitely, one. And if the patient still has a relapse in between, you can again increase the dose to 10 milligram BD for 4 weeks and bring it down.
Sir, in 4-5 cases which you shown in the study groups, which you had been presenting, in most of them, sir, you said that the biologics in fact had a relapse most of the time after stopping. What exactly has to be done in that case?
Sir, I told you it's like Agnipath, and that's true, like only 25%,
Yep.
because there will be 20% would be primary non-response initially when you start. 10% would be some other adverse event. Another 20% or 20, in fact, it's more than that per year would be a secondary loss of response, because they're proteins. Antibodies would form against them. Even adalimumab is 100%, even still antibodies would form against them. So once antibodies form against them, then they lose them.
And one small thing, sir, a practical thing which you normally see that on colonoscopy, if you keep on seeing scattered erosions all across, the biopsies are being done, and you get a report saying that non-specific colitis. How to go ahead?
So that's another issue, that IBD does not have a gold standard test for diagnosis. So diagnosis of ulcerative colitis or Crohn's disease would be made on a combination of appropriate clinical features, appropriate endoscopic findings, commiserating with the histology, and if the patient has Crohn's disease, and the radiology. So you do burn your fingers many a time. You label a patient as Crohn's disease, being treated as Crohn's disease for 1.5, 2 years on infliximab. Then you decide, let's take the patient for surgery. It's just a one stricture in the small wall, and it comes out as Meckel's diverticulitis with something which was causing a stricture. So you have to be very careful in terms of when you make a diagnosis, whether all these things add up, and be circumspect in every case. In ulcerative colitis, it's much easier to make a diagnosis. It presents also faster, and it's much easier to make a diagnosis.
Then Crohn's, right? I think Crohn is more of a hype. I think, I mean, it had been an excellent session. Thanks, Dr. Vineet. As usually a lovely talk. Good session.
Just for a picture, please. One photograph on the center of the stage, please. Sir. Thank you. For the next session, can I please invite Dr. S.K. Mishra and Dr. Praveen Sharma to please moderate this session. I would also like to invite Dr. Arvind Pokhriyal, Dr. Rupesh Shisht, Dr. Arun Singh Badoria, Dr. Shamsher Chauhan to please chair this session. Thank you, sir.
So the next topic is the current status of H. pylori in India. And the speaker is Dr. Usha Datta, who is a professor in PGI Chandigarh. Ma'am, please.
Thank you, Chairpersons. Good evening, everyone. And thanks to Dr. Anil Arora for organizing yet another stimulating meeting here. So I'll be speaking on the current status of H. pylori therapy in India. What are the issues which we will discuss? Whom to test, how to test, whom to treat, how to treat, and how to test for eradication. So whom to test? Anybody with antral gastritis, when you're doing an endoscopy, you should test for H. pylori because H. pylori is very common. A recent study from Bhubaneswar shows 83% of patients with dyspepsia have H. pylori infection. Gastric atrophy, this is again very common. If you look for, especially with NBI, you will find a large number of patients have associated gastric atrophy. These are patients who will go on to develop early gastric cancer. In Japan or in Taiwan, they will go behind all these patients. In India, because we see so much of H. pylori and so much of gastritis and atrophy, we just have learned to ignore it. Obviously, if there's an ulcer or a malignancy, we should be treating. Patients who are having iron deficiency, B12 deficiency, ITP, or a family history of gastric cancer. Also, we find that patients who have been on chronic NSAIDs or who are being started on NSAIDs who come with GI bleed, they have associated H. pylori, which is increasing the risk of GI bleed. Patients who are going to be started on long-term anticoagulants, it is a good idea to exclude H. pylori before we start because it is these two things have shown that there is an increased risk of bleeding if there is associated H. pylori infection. All patients of dyspepsia. There was a controversy in this about 10 years back, but after Maastricht 5's recommendation, as well as Rome 4 recommendations, all patients of dyspepsia, we have to exclude H. pylori before we call it functional dyspepsia. So a simple way to test them is a stool antigen test, or you can do a breath test before we label it as functional dyspepsia. And before starting empirical PPI therapy, it has been shown that if you do not look for H. pylori and do not eradicate it, empirical PPI changes the gut flora and increases the risk for CS stomach. So it is a very good method which we can do that patients who come to the OPD with dyspepsia, In most of the patients, we don't need an endoscopy to diagnose dyspepsia. Minimum a simple stool antigen test or breath test can be done before we start them on empirical PPI or PPI with prokinetic therapy. How to test? I will not go into that. All of you are aware of the various methods for testing. Stool antigen has emerged as a very simple method to look for active infection. Breath test again is a simple method for active infection. However, having radioactive C14 creates an issue. Rapid urease test is a very useful test during endoscopy, but there are two caveats. First, rapid urease test will be positive only if you have more than 10 to the power 5 organism in that gram of tissue. So if you have a little less of H. pylori sitting there, your rapid urease test will be false negative. Especially patients who are on antibiotics, patients who are on PPI, there's invariably suppression of H. pylori, so you'll get a false negative rapid urease test. And the second caveat with rapid urease test is that the kit should be of good quality, so that, and it should be standardized for our country and validated in our country so that we know that it works. And third thing which I found in our own endoscopy unit, that after the H. pylori test is done, the RUT is kept in front of on the table, and actually the room is at 22 to 25-degree temperature, and all these chemical reactions are better in a warmer place. So we have started shifting this to the lab area, which is at 25 or 30 degrees, and there we get more positivity. Histology, initially our pathologists were very enthusiastic in picking up H. pylori. Now nobody is looking for it because it's no longer a research interest. So histology quite often ends up missing H. pylori. And serology is of use only in epidemiological setting. So what are the caveats in testing? Whenever you're testing for H. pylori, ensure that your patients are not on antibiotics for minimum of 4 weeks. They're not on PPI minimum for 2 weeks. Otherwise, you will have false negative tests. And we can use urea breath test, stool antigen test, or rapid urease test. And if it is positive, our aim is to treat them. Seropositivity is of no limited use, especially only in certain situations. Say you find a maltoma and you find patient is seropositive, you would go ahead and treat. Otherwise, seropositivity is useful only in epidemiological purposes. So why should we treat? Because there was a debate about 15, 20 years back. If you see H. pylori, should you treat or not? So over the last 1 or 2 decades, a lot of data has emerged as to why we should treat H. pylori. It decreases symptoms, decreases incidence of cancer, decreases incidence of ulcer formation in a patient with H. pylori gastritis, decreases the incidence of bleeding, and decreases iron deficiency. But what are the risks, which was quoted very often in our country, is that cost of therapy goes up, there are logistics, resistance, and patients will get reinfection, and there's recrudescence of the H. pylori. So, however, overall, the benefits outweigh the risk, and that I'll show you in this study, very interesting study in which mass eradication of H. pylori was done to reduce gastric cancer incidence and mortality in a cohort study at the M.I.C.E Island. They eradicated in 16,000 patients, and they achieved 85% of the target population was covered. And you see what has happened is the H. pylori prevalence came down from 64% to 15% in the community. And the reinfection also went down because the total burden of H. pylori in the community came down significantly. So if we go here, then we will find that the reinfection is going to be lesser. Another very interesting thing they found was 53% reduction in gastric cancer from 2004 to 2016. So there is definite benefit in eradicating, and according to Maastricht consensus, they also are very clear that any H. pylori you see, you should eradicate, and it's a grade A carcinogen, and it's better eradicated rather than carrying it on you. So whom to treat? All symptomatic patients, all patients before we start PPI in patients with dyspepsia, NSAIDs, anticoagulants. Asymptomatic H. pylori infection also should be treated according to recommendations, and patients who have family history of gastric cancer, they also should have treatment for H. pylori. How to treat? This is the million-dollar question. This is what the main crux of today's talk is. Which drug, what dose, what duration, how to tailor it for our country. So what are the drugs we have? We have PPI, we have metronidazole, we have clarithromycin, amoxicillin. We have quinolones, rifabutin, bismuth, and probiotic. So these are the 8 drugs that we have. And let's see how to work around with them. What does PPI do? It's actually a most crucial drug in treatment of H. pylori infection. We have just considered it as an add-on, but PPI is what suppresses H. pylori directly, also allows H. pylori to enter into a replicative phase. When it enters a replicative phase, the antibiotics can act, and it also inhibits the efflux pumps and thereby preventing clarithromycin resistance. So PPI, good quality, high dose PPI is useful in the management of H. pylori infection. So what has studies shown that higher doses have higher efficacy. So 40 milligram BD dose is what is recommended for with PPI. And the newer generation PPI have higher efficacy than the older generation. Rabiprazole, esomeprazole, and vonoprazole are 3 drugs which have better efficacy than the lansoprazole and omeprazole group of drugs. So here you can see the eradication rate with omeprazole, 20 milligram BD is 20%, which increases to 40% with 40 milligram BD. And with esomeprazole steps up to 60%, and with vonoprazole steps up to 90%. So how you choose your PPI, what dose you give, and how much you give has a very important impact on your eradication therapy. So vonoprazole is a new drug. It is now not yet come to India. It's more potent than the routine PPI used at 20 milligram BD, has rapid, profound, and sustained acid suppression, and it's a potassium competitive acid blocker. So next drug is amoxicillin. Now, amoxicillin inhibits the cell wall synthesis of the H. pylori. So H. pylori has a cell wall, and that synthesis is inhibited by amoxicillin. And amoxicillin also inhibits clarithromycin resistance. So the interesting thing is that these drugs in combination prevent each other's resistance. So that is a very important thing. And earlier on, we used to give 750 BD amoxicillin. Then data came that we should give 1 gram BD. And now data is emerging, go to 3 grams, go to 4 grams. People in Japan, Vietnam, and Southeast Asian countries are using up to 4 grams of amoxicillin in a day and showing better efficacy. The other drug is clarithromycin. Now, clarithromycin is very important because world is divided into clarithromycin resistant areas versus clarithromycin not resistant areas. And now, especially with the COVID pandemic, with the amount of azithromycin which has been used, I think the amount of clarithromycin resistance is going to go up. And clarithromycin is given as 500 milligram BD. There is inhibition of the protein synthesis of the H. pylori. Quinolones, again, there is levofloxacin can be used, and we do use levofloxacin fairly regularly in these patients, and it inhibits the DNA gyrase, and moxifloxacin can also be used in these patients. But again, the problem in India is this is available over the counter, high chance of resistance. A recent study from Bhubaneswar has shown 61% resistance to levofloxacin. Metronidazole we have long given up because this has 80% resistance. So metronidazole was used earlier on, and it has direct action on the bacteria, but however has high chance of resistance. So we use it in a dose of 500 milligram BD. Now comes the wonder drug, as Vineet was trying to talk about Ramban in that situation. The present Ramban we have is a combination which includes rifabutin. Now, why is this rifabutin an important drug? First of all, it has high concentration of the gastric juice, up to 10 to 17 times increase in the gastric juice compared to the blood. Second is it is stable at a wide range of pH. So irrespective of your PPI, is going to act. Second is the resistance is less than 0.1%. And also using rifabutin doesn't increase the resistance to rifabutin. So they have done various passage experiments in the microbiology and shown that even if you do 10 or 20 such passages, there is no increase in resistance of rifabutin. Bismuth is another very important drug. So rifabutin, bismuth are very two crucial drugs which we have to learn to use it better. It inhibits the enzymes urease, catalase, and lipase, inhibits the adherence of the H. pylori, and it also overcomes the clarithromycin and levoflox resistance, and it's not affected by the metronidazole resistance. So in India, it's a cheap drug. It's now available, and it will form a cornerstone of therapy. So earlier on, pharma companies were hesitating because it had a low cost, low profit kind of a drug, but now it is freely available. There are various people who are producing it. Probiotics, again, this is another drug which we have. It has various mechanisms of action. Most important thing we have to consider is destruction of biofilms. So H. pylori also forms a lot of biofilms in the stomach, and that can be destroyed by these probiotics. So there are various mechanisms of resistance. I will not go into that. All that I would say is multi-drug resistance can happen due to biofilm as well as the cocoid forms of the H. pylori. So this is where we need multiple antibiotics in combination for adequate duration to work against this bacteria. And we have to realize that this bacteria has been there since the Egyptian mummies have been there on this world even before we came. So they are very intelligent beings. So we have to learn how to tackle them. Clarithromycin resistance, as I said, was initially 17%, and the present study shows 34% resistance from Bhubaneswar. And this is a study from Bhubaneswar in 113 dyspeptic patients. It was just published in 2022. They found 82% of dyspeptics having H. pylori infection, and you see on culture, 34% are having resistance. By the PCR method, clarithromycin resistance was seen in 11%. So culture is the more important component. So 34% are having resistance. And here you can see amoxicillin resistance is 3%, levoflox is 65%, and metronidazole is 81%. So this is very important data for our country. Antibiotic resistance in Asia, if you see a meta-analysis, it has shown that there's increasing resistance to levofloxacin. That is, clarithromycin is the blue line. Metronidazole also is having very high resistance, as well as the levoflox resistance is also rising. So resistant pattern in India, if we see, as I said, here is the new Bhubaneswar study, but overall we have had resistance to clarithromycin across India, and the multi-center study also showed clarithromycin resistance to as high as 45%. Resistance patterns in India, metronidazole 70% resistance, clarithromycin 17 to now 30% resistance, levoflox initially was 6%, now this is increasing. Amoxicillin resistance is still acceptable. Tetracycline now can be used back in our regimes because that resistance is not very high. So what we have started doing in our unit is that we have standardized a LAMP PCR to pick up H. pylori as well as pick up resistance to clarithromycin. So here you can see that here there is no H. pylori, that's a purple color across all the 4 tubes. And here you have, this is the negative control, here H. pylori is positive. H. pylori is positive, that is the blue one, and there is no clarithromycin resistance. So here H. pylori is positive, but there is clarithromycin resistance. And here there is H. pylori positive with clarithromycin resistance. There are 2 particular mutations we are looking for. So basically this test on the bedside in about half an hour to 1 hour can tell us is H. pylori present or absent by PCR. And if it is present, is it resistant to clarithromycin or not? So this is a very useful test. In Vietnam, they regularly give anti-H. pylori therapy only after culture reports, but I don't think that's practically possible in our country. And we are now trying to develop levoflox testing along with a Korean company to see whether we can do a LAMP PCR just like this for levoflox also. So what regime? Now there are certain standard terminologies. So I'll just take you through this simple jargon and make it simplified. Standard triple therapy is 3 drugs. This is PPI, amoxicillin, clarithromycin. Earlier we used to use metronidazole, but right now metronidazole is out. So we have PPI, amoxicillin, clarithromycin given for the first week as well as the second week. So that is what we mean by standard triple therapy as of today. What is sequential therapy? Sequential therapy, you give 2 drugs initially, and then you make it 3 drugs in the next week. So this is sequential therapy, 2 drugs followed by 3 drugs. What is concomitant therapy? It is 4 drugs in the first week as well as 4 drugs in the second week. So it's 4 drugs for 2 weeks. So this is PPI, amoxicillin, clarithromycin, and metronidazole. You can instead use also tetracycline instead of metronidazole. So what is hybrid therapy? Hybrid therapy is 2 drugs first and then 4 drugs later. So various combinations people have tried at various points of time. And now is the other thing, that is the bismuth quadruple therapy. I'll share these slides with all of you. I can put it up on the net. So just listen and that will give me greater satisfaction. So bismuth quadruple therapy has 4 drugs. So it's 4 drugs, that is PPI, metronidazole, tetracycline, and bismuth. And the other combinations, PPI, amoxicillin, clarithromycin, and bismuth. So basically you have these 4 antibiotics, out of which you choose 2, and you add bismuth and PPI on either end. So just to recapitulate, standard triple therapy in our country is PAC, that is PPI, amoxicillin, clarithromycin for 2 weeks. We don't use so much of sequential therapy. So if I would like you to concentrate, I would like you to focus on the concomitant therapy, that is 4 drugs for 2 weeks. And the other one is bismuth quadruple, that means again 4 drugs for 2 weeks, but here now we have a bismuth also in place. So once we know these terminologies, we will be using it. So I would just suggest that you get familiarized with it. Again, repeating, standard triple therapy, 3 drugs for 2 weeks, concomitant therapy, 4 drugs for 2 weeks, and bismuth is 4 drugs for 2 weeks, but it has the bismuth in it. That's all it is. So what is the eradication rates? It's somewhere between 75 and 87. WHO says that you should use a regime which is giving 90% plus eradication rate. None of our regimes are giving right now. So when you have dual resistance, then the best drug we have is bismuth quadruple therapy. If you have clarithromycin resistance, we can still use concomitant therapy. As I said, in the presence of PPI and amoxicillin, even if you have clarithromycin resistance, these drugs compensate for each other. So even in clarithromycin, you can use this regime, but you can't use just triple drug regime. So if there is clarithromycin resistance, the drug of choice is this 4 drugs for 2 weeks or bismuth based for 2 weeks. So that is the learning point of this slide. So which one is better? So there's a meta-analysis which has been done, and this is a meta-analysis I would like you to focus on. And here you can see that compared to the standard triple therapy, amoxicillin PPI dual therapy has some benefit. Here, vonoprazan based triple therapy, you see, has 3.8 times better chance of eradication. So this is useful. And the other one which is useful here is 4 drugs, that is PPI, amoxicillin, clarithromycin, and metronidazole. So this is another regime which gives us 2 times more efficacy. So vonoprazan based triple therapy is right now the best we can have. So if you have vonoprazan, rifabutin, and you have levoflox, I think that is the Ramban we have against H. pylori. So this is a network meta-analysis. So which regime we have seen? Quadruple therapy, concomitant therapy is better than triple therapy, and 14-day regime should be the mainstay. And here I would say these are the guidelines. In low clarithromycin resistance, we use these 3 drugs. That is the standard triple therapy. In high clarithromycin resistance, we use 4 drugs, and which has clarithromycin with added bismuth. That is what I would suggest in our country. If there is dual resistance, then PACB would be our best choice. So I would think that this would be the first line. This would be our second line therapy in our country. So Indian guidelines, we met in Bhubaneswar and we had a consensus, and this is what is the Indian guideline, that PPI, amoxicillin, clarithromycin, if you do not know the resistance status, and if the patient has failed, then or has high clarithromycin resistance area, we use a bismuth-based regime. So how do we improve the efficacy? Increase it to 14 days, use new generation PPI, use high dose amoxicillin, add bismuth, and add probiotics if possible, and ask the patient to stop smoking and reduce obesity and other lifestyle measures. So as I said, by adding bismuth, we are adding efficacy by 10%. If you add probiotic, you add efficacy by 13%. And we add again bismuth and probiotic 11%. And if you replace clarithromycin by levoflox in low resistance area, we are adding 10%. And if we replace PPI by vonoprazan, 13%. So if time is up, I will stop here and I'm ready to take questions.
Good evening, ma'am. Excellent presentation.
Thank you.
My question is about, you said rifabutin could be one of the Ramban. What about rifaximin? Because it is of same class of drug. So has that been tried? And now we have been using rifaximin for so many indications, say IBS. And so how does it affect the H. pylori?
Yeah, I haven't looked into this particularly, rifaximin versus rifabutin, but rifabutin is cidal drug, rifaximin is bacteriostatic drug. And second is rifabutin is a different drug compared to rifaximin, though they are all from the rifamycin group of agents. I do not expect rifaximin to have a direct effect on H. pylori, but I'll have to look into literature before I can give you a definitive answer on that.
One more, which probiotic?
Yeah, there is. I had a slide on Lactobacillus reuteri has been tried in a study from Taiwan, from Thailand, and shown that it adds to efficacy by 11%. So we have to also see the cost at that point. So we should know that in order to improve an efficacy of 11%, if patient can afford, then we can add. If the patient cannot afford, it need not be the most important. So I would again here emphasize that the most important thing in India is, just once again, the most important thing in India here is to ensure 14-day therapy, to ensure compliance, to hit hard when you see the thing first time, and give amoxicillin minimum 2 grams BD or minimum 1 gram BD if to start with, and add bismuth to all your regimes, and ensure that all these patients you test for eradication after you have given the therapy.
What is the relapse or the recurrence rate after these therapies? Better therapy, lesser recurrence rate, or something like that?
Yes, sir. The recurrence rate, see, once you eradicate, you think that you have got the H. pylori out. But actually, studies from India which have done PCR, they have shown that after you have eradicated also so-called RUT is negative, there may be still H. pylori DNA sitting there. We don't know whether it's dead or alive. But for all practical purposes with H. pylori, you have to suppress the bacteria to such an extent that you gain control over the stomach again. Otherwise, stomach is the one.
Do we test again? Do we sort of, how do we know that the job is done?
Yes, sir. The job is done when you finish your therapy for 2 weeks, you give PPI for another 2 weeks, and then completely off all drugs for 4 weeks. And then you test a stool antigen for H. pylori, or you can do a breath test at that time. If the patient had an ulcer, then it is a better idea to go back in and look for RUT. Otherwise, the best test is stool antigen test. That's what we routinely follow in our place.
Thank you.
Madam, I have one question that regarding RUT test, what happens that sometimes after 1 or 2 days, patient comes with the RUT kit and they say now the color had turned to pink. So exactly what is the time at which it should be interpreted? And can RUT be done with the gastric fluid instead of taking biopsy?
RUT has been standardized with the biopsy tissue. It should be read at 30 minutes and should be declared negative at 24 hours. So you cannot wait eternally for it to be become positive. So the reading is at 30 minutes and then you store it. Next day you declare negative, it remains negative till 24 hours.
Thank you.
Excellent. Do you still believe that in India also H. pylori is causing gastric cancer? Number one. Number two, you quoted that island, M.I.C.E. island. The prevalence there is 70 per lakh. We don't have that prevalence in India. So in a high prevalence state, no, we did a study, we did a lot. I was fascinated with H. pylori when it was invented there. So we did a study in normal, healthy individuals. I underwent endoscopy, Dr. Manisha, my father, my mother, everybody, healthy individuals. All of us were positive. So with the population, huge population, if practically everybody is positive, if you do it well, practically everybody will be positive because of our weight. Then we did genetic studies. Our H. pylori is much different from that in the East Asian countries. We are more like Europeans and we behave like Europeans, not only English and the table manners, but otherwise also genetically we behave like that. Third point was if you do an endoscopic biopsy with H. pylori infection, most of them is chronic infection. There's nothing acute infection. So the acute infection causes apoptosis and malignancy, not the chronic infection. It's an indolent infection which is going on. So we need more studies to confirm that gastric cancer is caused by H. pylori in our country.
No, the the data which I have shown is based, and the recommendations worldwide is based on the fact that H. pylori is a known bacteria which can cause malignancy. Now, in our country, whether we have a different conundrum, we do not know. But I remember Dr. Goshal's thing on Asian enigma on H. pylori. I don't know, maybe there are certain protective factors which are there in our diet, which is not allowing us to have as much gastric cancer as our Western counterparts or our
No, I
Eastern
think
counterparts.
is it the genetics? Genetics are different. The inflammation is different. The H. pylori strain is different.
It could be there, sir, but all that I'm saying is if you see H. pylori in the present day, you should treat it. That is what is my submission. And
I need an Indian record. If you have for Bhubaneswar, then we have to follow it. But is there consensus, Ghoshal?
We did a study many years ago, actually, and we compared our H. pylori with Japan, Nepal, Bangladesh. So interestingly, what we found was most of our strains are CAG negative. And the amount of inflammation, we took biopsies also. I mean, it's quite an old study now. And we took biopsies from these different regions also from this. So it appeared that the inflammation also was much lesser compared to that. And it was the neutrophil predominant thing more than lymphocyte. So possibly our H. pylori may not be as bad. I mean,
yeah,
and it was quite in contrast with that of Japan. So, and it was Japan itself conducted the study. The funding was from there, but it was quite different.
Yeah, we have learned many times that hepatitis B, hepatitis C, so many viruses have different kind of genotypes, and that can affect various phenotypes in the patients. We are aware of that, but all that here, the point which had to be made is if you see H. pylori, how to treat in our scenario.
Dr. Usha,
Yes.
I'm here. I mean, one question. I'm in the back.
Okay, yes.
Madam, it was wonderful presentation. Firstly, I have two questions for you. One, first, I'm Dr. Arvind Gopi from Bengaluru.
Thank you.
Okay, my first question to you is, when do you recommend a follow-up endoscopy to which set of patients post-therapy? My second question to you is, of late, I'm seeing number of patients coming back to me with reflex symptoms, GERD symptoms, post-treatment. In such patients, which is the best the combination can we choose to prevent reflex?
Yeah, very good questions. The first is all patients with H. pylori therapy need to be tested for eradication. The test need not be endoscopy. Test, as I said, could be just stool antigen or a breath test. The only caveat is patient should be off PPI and antibiotics for minimum of 4 weeks prior to testing. Otherwise, you will get a false negative result. You need to do an endoscopy only in one situation, that is if there was a gastric ulcer, because it could have been malignant, you may miss it. So you have to ensure that the gastric ulcer has got treated and healed completely. So gastric ulcer is the only condition where you have to go back with the endoscope. Otherwise, stool antigen or breath test should be sufficient.
Ma'am, the second question, the reflex.
Reflux. So there was a lot of controversy whether H. pylori treatment increases GERD. Actually, it has been found, various meta-analysis has been found and shown that it actually does not increase. Definitely the gastric mucosa now becomes more active and is producing acid. So it is the LES mechanism which is defective and not the excess acid because of the H. pylori therapy. Actually, acid has a protective role in the gut. H. pylori allows the gastric acid to come back into protective action.
I think we can have the last question by Dr. Chaudhary.
Same question. See, the incidence of positive this thing on biopsies is very high in India. What is your experience of what is the really incremental benefit that you get by managing H. pylori? Say 100 patients of dyspepsia, positive for this thing, H. pylori. What is the real incremental benefit in clinical practice when you give this syrup and eradicate bacteria?
In non-ulcer dyspepsia, as it was called, the number needed to treat is 14. Another study has shown number needed to treat is 10. So apart from, we can keep this dyspepsia component out, yeah, because the focus of today's talk is which regime to use if there is a positivity. And regarding dyspepsia, there is a lot of controversy, but international guidelines suggest that we should treat it. In India, we have challenges because of the cost of therapy, compliance, resistance patterns. So that is why in India, I was trying to bring out what should be our regimes in our country.
Thank you, ma'am.
Thank you.
Thank you for the interesting session. And I think we conclude this session.
Please, can I request you for a picture? For the next session, can I please invite Dr. Manisha Dwivedi, Dr. S.L. Varur for moderating the session. I would also like to invite Dr. Kumar Abhishek, Dr. Ravikant Gupta, Dr. Jayant Ghosh, and Dr. Apurv Siva for chairing the next session. Thank you.
The next talk is by Dr. Uday Ghoshal. He's heading the Department of Gastroenterology at Sanjay Gandhi, Lucknow, and he'll be talking on the unholy trinity of gut, diet, and microbiota in IBS. Dr. Ghoshal.
Thank you. I thank the organizer for giving me this opportunity, an important topic. IBS, the unholy trinity of gut, diet, and microbes. Let me tell you what was our understanding of IBS. We thought IBS is functional. The functional was further inappropriately thought to be idiopathic or cryptogenic. And we thought the patient were neurotic, apprehensive, but otherwise healthy individual with an imaginary illness. And this led to a lot of disservice to this patient. They really suffer, but the physician ignored them. Now, today, what is IBS? IBS is what food do you eat, what microbiota you have, because food is metabolized partly by microbiota, how this food is handled by the host and microbes. Now, is there an immune response to the antigen that is produced by the bacteria on the action on the food, and how this immune event are sensed by the nervous system? So if you look at this now, a lot lies in the gut. Fire lies in the gut, but also there is a sensing at the brain level. So that is the reason in Rome 4, we changed. We said IBS is not a brain-gut disorder. It is a gut-brain disorder. Primarily, the problem is in the gut. The secondarily is in the brain. And in fact, many of the studies that looked at IBS psychological issues, what did they do? They took patient of IBS, did their psychological evaluation. They took healthy people, did their psychological evaluation, and they found IBS have more often psychological issues, and they thought IBS is due to mental problem. And obviously, if you take any chronic disease, you will have mental illness among them because they are not well. So therefore, they develop secondary depression, secondary anxiety, and you thought anxiety is causing IBS. Now, what is IBS? IBS is, according to Rome 4 now, at least 1 day per week in last 3 months, pain in the abdomen associated with 2 or more of the following. The pain should be related with defecation, associated with change in the frequency of the stool, and associated with change in the form of the stool. And the patient must not have alarm symptom. What is alarm symptom? If age is more than 45 years at the time of onset, it is an alarm symptom. Anemia, blood in the stool, unintended weight loss, nocturnal symptom, fever, abdominal mass, and family history of cancer. It does not mean a patient who has alarm symptom cannot have IBS. It only tells you, please have adequate investigation to rule out an organic illness before leveling them as alarm symptom. As a physician, you can't manage a patient of IBS or as a gastroenterologist until unless you subtype them, because subtyping could be a patient can have constipation predominant IBS, somebody can have diarrhea predominant IBS, somebody can have pain predominant IBS, and the management will differ a lot. Like a constipation patient will have a different treatment than a diarrhea patient. But more than that, you have to see, are there biological factor causing this symptom? Because we brought in a concept in Rome 4, multidimensional clinical profile, where we said, look at, is this IBS? See how severe it is. Are there psychological issues? Are there biological factor? Are there dietary issues? So all these you have to look into and manage them from multiple sides to really do good to them. Now, if you look at IBS-C, what could be the biological factor? Fecal evacuation disorder. What is fecal evacuation disorder? It is like achalasia of anal sphincter. Slow colon transit. The colon is not moving at all. So therefore, patient has constipation or a combination of the two. In IBS diarrhea, you have a lot of biological factor. It could be lactose malabsorption or fructose malabsorption, bile acid malabsorption, non-celiac wheat intolerance or FODMAP intolerance, small intestinal bacterial overgrowth and dysbiosis, immune activation, and post-infection. I will elaborate on some of these, not all. How common is small intestinal bacterial overgrowth in IBS? First, let me tell you what is small intestinal bacterial overgrowth. Rupa was talking about dysbiosis. So dysbiosis include increase in the number of bacteria in the small bowel or change in the quality of gut bacteria. So increase in the number of bacteria means there are more than 10 to the power 5 colony forming unit per milliliter of aspirate bacteria on culture. This is the conventional definition, but we have changed this definition. We brought in a concept called low-grade small intestinal bacterial overgrowth, which is more than 10 to the power 3 colony forming unit per ml. The reason is, even if it is more than 10 to the power 3, we found pathologically it is important. It changes the symptom pattern. And if you treat the patient with antibiotic, they recover more often than those who have less than 10 to the power 3. So what is small intestinal bacterial overgrowth? It is conventionally more than 10 to the power 5. And we did a meta-analysis taking all IBS patient studies and control studies and looked at the relative risk of bacterial overgrowth among IBS patients. And as you can see, IBS people have 7-fold greater chance of having small intestinal bacterial overgrowth than healthy control. Look at further subtyping of IBS. If it is diarrhea predominant IBS, chance of bacterial overgrowth is much greater than if it is constipation predominant IBS. What is gut microbiota dysbiosis? Rupa was talking about. It is a qualitative change in the gut bacteria by next generation sequencing. So you look at 16S rRNA gene by next generation sequencing, you can get an idea of phyla, you can get an idea of taxa. Sometime even you can go to that level of resolution that you know the species. Now, this is a meta-analysis which looked at all the studies till that time in 2019 on gut microbiota dysbiosis or fecal microbiota dysbiosis, and they looked at good bacteria. What are the good bacteria? Lactobacillus, Bifidobacteria, and Enterococcus. And what they found, yes, most of the studies showed that good bacteria got reduced in number among IBS patients than control. But only thing is, let me tell you, that when you study microbiota by next generation sequencing, there are too many confounders. Like Dr. Rupa told you, diet changes the microbiota. Medicines changes the microbiota. If there is a change in the motility, it changes the microbiota. So if you do a case control study only, it may be an epiphenomenon rather than a cause and effect relationship, because the IBS patient may have different diet than control. They might be taking different medicine, control might not be taking. So therefore, interpret these studies with a caution. This is bad bugs, and they found bad bugs were greater in number among IBS patients than control. So whatever is a caveat is there could be an epiphenomena just by doing case control study, that is doing next generation sequencing of the fecal material. There could be an error, but still it looks like that patient of IBS have different gut microbiota than control, whatever may be the reason. And there is a concept called diversity. What is diversity? It could be alpha diversity or beta diversity. Yeah, alpha diversity is intra-individual diversity, or beta diversity is inter-individual diversity. If you take control and take cases and look at the diversity, are they diverse? Now this is beta diversity, and most studies showed that patient with IBS had a reduced alpha diversity, and when they were compared with the healthy population, that increased beta diversity. So therefore, this is the conclusion till now. Now, what happens is if there is an increase in the bacterial overgrowth or increase in the bacteria in the gut, and if there is a change in the quality of bacteria, could it lead to immune activation? The immune activation is important because this is the one which induces inflammation. And let me tell you, low-grade inflammation is a hallmark of patient with diarrhea predominant IBS, as shown in the multiple studies. So what we did is, this is a very interesting study where we looked at gut microbiota of IBS patient by RT-PCR or real-time PCR. We did fecal microbiota among IBS patient, but also we looked at different cytokine by biopsy of the gut mucosa, that is jejunal or duodenal mucosa. And we looked at certain pro-inflammatory cytokine such as IL-6, also chemokine such as CXCL11 and CXCR3. And we looked at anti-inflammatory cytokines such as IL-10. And we found, depending upon what type microbe they had, there was a different expression of cytokines. And therefore, the gut microbiota dysbiosis is leading to different degree of gut inflammation, which might be causing the symptom. Now, we cannot talk about anything now in 2022 without talking about COVID, because we have all seen the pandemic. And I tell you, we thought COVID had a lot of things to do with infectious gastroenteritis. For example, COVID patient had diarrhea. We know fecal PCR, if you do among COVID patient, half were positive. They had SARS-CoV-2 RNA in the feces. Gut microbiota dysbiosis is known in COVID. Patient had increased permeability. There was excess of serotonin on rectal biopsy of COVID patient. Therefore, we gave this hypothesis in 2 of our review articles that COVID will lead to increased IBS. And that further proves gut may be at fault. We wanted to prove this. So therefore, we did a study. We took about 280 patients of COVID-19, both symptomatic as well as asymptomatic. And we took 264 control. This study was done in SGPGI as well as 3 centers in Dhaka, Bangladesh. And we followed them up at 3 months and 6 months. And what we found is, yes, 10% of the COVID patient on long run develop functional gastrointestinal disorder, which we call as disorder of gut-brain interaction now. And predominant type of disorder was IBS, but also functional dyspepsia and its overlap with the IBS. We looked at what is the type of IBS in them. It is predominantly diarrhea, predominant IBS, and same was substantiated by another collaborative study from US and Mexico. Now, does this post-infection IBS, can it be explained by gut microbiota dysbiosis? Here is a study from Hong Kong, and they showed post-acute COVID-19 syndrome was associated gut dysbiosis which lasted longer, even up to 1 year after SARS-CoV-2 clearance. So one of the pathogenetic mechanisms that we thought that the patient of COVID will lead to development of IBS due to gut microbiota dysbiosis was substantiated by this study and yet another study. And in fact, in this particular study, they looked at SARS-CoV-2 RNA in the feces and gut microbiota dysbiosis, and they found those who excreted the virus longer, that is SARS-CoV-2 virus longer, are the one who had more gut microbiota dysbiosis. Now, can we manipulate the microbiota? We know we can manipulate by probiotic, by antibiotic, by fecal transplantation. But let me tell you, fecal transplantation story is different. In IBS, we do not do fecal transplantation for its treatment. FDA has given a black box warning, and most of the studies, randomized controlled trials showed fecal microbiota transplantation did not work in IBS. So therefore, I chose antibiotic data, and there is a randomized controlled trial. We took 80 IBS patients. Some had bacterial overgrowth, some did not have. Then we did a stratified randomization. Those who had bacterial overgrowth randomized to norfloxacin or placebo. We did norfloxacin study because at that time rifaximin was not there in this country. SIBO negative, similarly norfloxacin and placebo. And we found if you treated IBS patient with SIBO with norfloxacin, you have 85% resolution of symptom compared to those who did not have SIBO, where the resolution was only 25%. So what does it mean? That if you treat a patient after having bacterial overgrowth, you are more likely to predict a response than those who did not have bacterial overgrowth. Now, obviously, this study included largely non-constipation IBS patient. In fact, target study took non-constipation IBS patient because non-constipation IBS or diarrhea predominant IBS is more likely to have bacterial overgrowth. Does antibiotic work in constipation IBS? Yes, it does. If a constipation IBS patient has excess methane in their breath, that means they are methanogenic bacteria in their gut, these patients have slow colon transit because we know methane is a nerve gas. It slows the colon transit. And there, if you treat with rifaximin or rifaximin plus neomycin, one retrospective study by Mark Pimentel, another randomized controlled trial by Mark Pimentel, and our own randomized controlled trial, yes, by reducing methane, you can improve transit, you can improve constipation, but temporarily the bacteria again come back, methanogen again come back, and the constipation recur. How about FODMAP? FODMAP is fermentable oligo-dimonosaccharide and polyol food. So a lot of these food, like I have shown here, upper panel shows high FODMAP foods, lower panel shows low FODMAP food. High FODMAP foods produce more gas. So therefore, it has more sort of osmotic load in the gut, more gut distension, more gas, more pain, more bloating, and more diarrhea. Now, if you eliminate this high FODMAP food in the diet initially proposed by Peter Gibson from Australia, now we have multiple studies from all over the world, including one study in functional dyspepsia patient randomized controlled trial by Ludhiana group, Dr. Umesh Goel, that it works. The low FODMAP diet works in IBS. But let me tell you, India needs more study. You know why? We did an analysis recently and look at the vegetarianism frequency in India. It's a lot. In green areas of India, mostly northern part, 81 to 90% people are vegetarian. And giving low FODMAP diet to a vegetarian is so difficult. So therefore, this all Western study, you cannot extrapolate to India unless you produce more study. How feasible is a low FODMAP food in a vegetarian patient? Further, this is compounded by lactose malabsorption. Look at the West. Europe, lactose malabsorption frequency is 3 to 10%. In India, lactose malabsorption frequency is 80%, and we have some data to show that. Now, depending upon whether somebody is a wheat eater, vegetarian, and lactose malabsorber, this fellow is very difficult for low FODMAP diet. On the other hand, if somebody is a rice eater, non-vegetarian, and is not a lactose malabsorber, it is easier. So it is very important that we do multiple studies on feasibility, patient compliance, efficacy before we jump onto the law FODMAP diet in India. So therefore, let me tell you, my summary slide is there are multiple putative therapeutic targets at the gut level in IBS patients. So it is not all in the brain, and each of these putative therapeutic target can be handled pharmacologically as well as non-pharmacologically. It is a busy slide. I can't elaborate everything because I have 1 minute left. But this you can get as a review article in Journal of Neurogastroenterology and Motility. But finally, let me tell you one thing. This is the treatment of IBS. I've given a table summary. This is very, very important. This is a study called MANTRA. MANTRA is a study by Gerald Holman from Australia. And what they did is took IBS patient and they asked the gastroenterologist to give standard management. Gastroenterologists are busy in looking at the gut through the endoscope, taking biopsies and all these. So they are not interested to go beyond that. Now another group, they were randomly treated not only by a gastroenterologist, but a psychologist, a dietitian, a counselor. And therefore, the randomized control trial showed MANTRA was better. What was MANTRA? Where it was a combination therapy by a psychologist, gastroenterologist, dietitian, counselor was far more superior than a gastroenterologist alone. So we have to introspect, can we develop team like that to manage our patient better? So let me conclude. IBS is a multifactorial in pathogenesis. Those central factors may be important, but peripheral factors are of major importance, and all the contributors in the pathogenesis of the disorder may be the target for treatment, and MANTRA is better than gastroenterologist given single therapy. Thank you so much.
Thank you very much, Dr. Ghoshal, for an excellent talk and finishing also in time. We can have some quick questions, comments from the audience now.
Very nice, Uday, as usual. Methane has many beneficial properties, anti-inflammatory, anti-apoptotic. So if we get rid of methane, are we harming people?
Yeah, what
methane is coming as a therapy for many.
Yeah, very important question that you said. See, I don't think it is a standard of care to reduce methane by rifaximin, neomycin in constipation patient. But the study that we did was to prove the pathophysiology that methane actually slows transit and causes constipation. So it was like a proof of concept study by hitting the methanogen, reducing methane, and whether transit improved and constipation improved. So therefore, it is not a standard of care. Nobody recommends that every methanogenic bacteria should be treated, but in a difficult patient where nothing is working, this may be one of the rescue options.
But if you give rifaximin or norfloxacin, you're killing many more bacteria than the
Yeah, that's right. You are right.
So it can be anything else also.
Yeah, that's right.
Dr. Arora?
Excellent talk, Dr. Avjay, as usual. My question is, are we justified in calling it a functional disease? Why
Yeah.
is it that structurally there has to be something wrong to produce a plethora of symptoms? It is a big mimicker of anything and everything. IBD, malabsorption, celiac. Should we still call it functional?
Yeah, right. You are right. You see, once upon a time, IBD patients were treated by frontal lobectomy. They used to hit the brain to cure IBD. So from there, we went and now know what is IBD. I think a lot of IBS patients are low-grade IBD. So that is the reason why in Rome 4, we said remove the term functional. So therefore, the functional gastrointestinal disorder are now history. Now, these are called disorder of gut-brain interaction because we do not have a better name. Now, in Asia, we have given a new name. Obviously, Asians are not as sort of popular in the world as the Americans are. So therefore, this name is not so much popular. This is microorganic disorder. So we are calling in Asia, this is microorganic disorder, that is organic at microscopic level, but Rome is saying these are disorder of gut-brain interaction. So today, whole world is saying no functional, please.
Go ahead.
Sir, lot has been said about SIBO. How good is this hydrogen breath test which we do by a gastrolyzer in picking up SIBOs in that?
It is very poor, I tell you. Sensitivity of breath hydrogen or breath testing to pick up SIBO is only 30 to 40%. 30 to 40%. Specificity is 90 to 100%. So that's why now we have gone one stage above this. What we do is we have developed a gas sensing capsule. Like you do capsule endoscopy. Obviously, this is not our development. This is developed by Australia, but we have taken this machine. It is under testing now, so we are testing it. So what happens is this is a capsule. Patient just eats the capsule. The capsule goes inside the gut, takes the hydrogen, and give the signal in our outside computer, and you see intraluminal hydrogen. There are some data published in Elementary Pharmacology and Therapeutics which showed it is superior to breath hydrogen, because breath hydrogen means a small fraction of hydrogen that is absorbed, goes to the circulation, comes out in the lung. That is what we are picking up. On the other end, luminal hydrogen will be better. So we are in the search for a better test. Obviously, Mark Pimentel proposed lactulose hydrogen breath test early peak criteria. Absolutely fallacious, absolutely fallacious. Glucose hydrogen breath test is better in specificity, poor in sensitivity. We need a better test. That is what we are working on.
Yes. Sir, one of the important criteria for labeling IBS is having pain. But in India, most of the patients don't have pain. They just have bloating and discomfort. And the other thing, when we subtype the IBS, we use by Bristol's stool chart. But in India, patients say that they have constipation, but they go to stool at least 4 times, 5 times.
So very good.
It's very difficult.
So very good. You said what we have been saying to Rome, but Rome did not listen so much to us. We said in Rome 4, pain must not be essential. Pain must not be essential. And we said bloating must be included. But it is a consensus process. So we might have been minority, but the majority were a lot of people in all over the world. So when the criteria came out, we saw pain was made essential. But now everybody is scratching their head, including all the Rome big guys. You know why? Because look at the data of Rome 3 versus Rome 4, even from Europe and US, gastroenterology paper. Rome 4 diagnostic criteria gave 50% sensitivity of Rome 3. That means those were Rome 3 diagnosed, 50% of them were Rome 4 diagnosed. So it is not only in India, but everywhere in the world. Pain is not prominent. But what happens is maybe in US, I say in US, you say no pain, no pain, no pain. This is what you will teach your children. We teach our children no pain, no gain. So try to learn how to tolerate pain to have a gain. So the pain threshold of the two population are different. We say no pain, no gain. They said there must not be any pain. So there is a cultural difference. So probably I believe in Rome 5, they will listen to us because they realize there is a mistake there. They reduce the sensitivity to pick up the diagnosis by Rome 4 to 50%, and it is a global phenomenon. Now, what happens is your second question is yes, in Asia, we said type 3 stool is constipation stool. Rome says type 1 and type 2 is constipation stool. In Asia, we said type 3 is also constipation stool. And we have shown data from Korea, from India, from China that we are right. But obviously, this is an Asian sort of situation. So we should practice that. Type 3 is also constipation stool, but Rome will not listen to that because their gut transit time is different than ours. We take milk, which is a laxative, they don't take. We take vegetarian diet, which is huge in bulk. All these three actually constitute what type of stool will pass, what volume, what consistency, how many times.
Dr. Ghoshal, quickly 2 questions I wanted you to answer. All of us for the IBS diarrhea subgroup using antibody like rifaximin with good results. The question is, does this antibody therapy modify the natural history of the disease, long-term natural history? And how many courses of antibody can you give to these patients? After 6 months, the patient again started with diarrhea. You treated after 6 months again you have diarrhea. How many courses?
Very good questions. I tell you, Antibiotic in IBS currently should be considered as rescue therapy, like we do in IBD. When other option did not work, then only go to rescue, because still there are skepticism. There are skepticism using antibiotic, it's bad effect. Though you know rifaximin is good drug, only 0.4% is absorbed, but still there are skepticism. As far as recurrence is concerned, there are good studies, including one study by Sanjeev Sajdeva. I kept on pressurizing him, publish this data. Whole world is waiting for this data. I don't know why he did not publish. Now, what happens is he showed rifaximin treatment successful. He did glucose hydrogen breath test at 3 months, at 6 months. He found 50% had recurrence at 6 months. What does it mean? Recurrence is rather the rule rather than the exception. Now, can you treat recurrences with rifaximin again? Look at the Target 3 study. So Target 2 was published in NEGM. Target 3 was published in Clinical Gastroenterology and Hepatology by Anthony Limbo. Now, Target 3 showed repeating second time, repeating third time, it worked. Only thing is Target 3 showed something more interesting. They found severity of the symptom in the rifaximin treated patient during recurrence was lesser. So what does it mean? Probably it modifies the history a little bit. I don't know whether it should be called as natural because we are interfering with rifaximin, but it reduces severity even in the long term. So I think, sir, I have given answer to all your questions.
Sir, how long can we use loperamide for IBS-D?
Because loperamide, all these are sort of drugs which are not like rifaximin. You can use as long as you need to. So only side effect is constipation. So if somebody is constipated, reduce the dose.
Another question is, these days some patient will come and tell you, look, doctor, I stopped gluten, my symptoms improved considerably. And you test them, you do not find any genetic or serological marker or any mucosal change or celiac disease. What should be our advice to these patients? Should they really go on gluten?
Yeah, that's right. So actually, there is a term called non-celiac gluten sensitivity, which is a misnomer. Like Govind Makharia has also published data on non-celiac gluten sensitivity among IBS patients. I think it is less than 1% if I correctly recollect the figure. Now, what happens is the term non-celiac gluten sensitivity is a misnomer. You know why? This is non-celiac wheat sensitivity. There was a beautiful study. People with IBS, those who recover, they were randomized to given gluten in the form of capsule or placebo. And they found recurrence of the symptom was equal among those who received gluten and placebo. What does it mean? That means it is not to do with gluten. It is to do with the FODMAP containing constituents of the gluten containing food. All the foods which are high in gluten, such as wheat, are also high in FODMAP. So that's why we want the term to be changed as non-celiac wheat sensitivity. And this is because of the FODMAP content and not because of the gluten content. Now, they should all be using low FODMAP diet as long as possible. Only thing is using low FODMAP diet in the long term is very difficult. Also, it changes microbiota to a bad side rather than the good side. So therefore, what we do is that give them low FODMAP food for a while, then ask them to re-challenge different food one at a time and identify which are the foods among the high FODMAP food which are important and causing intolerance in them, and only avoid those food rather than the whole chunk of low FODMAP food which are too many in number.
Last question. Out of a plethora of pre and probiotics available, which one would you suggest and for how long in these IBS patients?
You see, IBS, if you look at randomized controlled trial of probiotic and IBS, including meta-analysis, results were quite mixed. But one thing they showed is it worked better in non-constipation IBS. Second, it worked better for bloating patient. So bloating is a symptom where I use probiotic. Now, if you say which probiotic, lactobacillus group of probiotics are better because obviously they alter the pathophysiology of lactose malabsorption as well as FODMAP related issues. Second is multi-species probiotic may be better than a single species.
Any comments from the panelists? Quickly. I think we already.
Thank you, sir.
Okay, well, thank you very much, Dr. Kushal. We had an excellent talk. I think usually in IBS talk, we do not get so much of enthusiasm, so much of question, but you really made it very interesting. Thank you. Thank you very much.
Thank you.
So we request you for a picture in the center of the stage. For the next session, can I please invite Dr. Alok Gupta and Dr. Sanjeev Sachdeva to moderate the session? Also, can I please invite Dr. Sumita K. Shresht, Dr. Rabin Koirala, Dr. Rajneesh Monga, and Dr. Saroj Dubey to please chair this session. We're also live on YouTube, so any comments, any posts you want to put, we'll have a team to answer it as well. Dr. Manoj Joshi, can you please moderate the session?
It's a great pleasure to introduce Dr. Govind Makharia, Professor of Gastroenterology at AIIMS, New Delhi. He's going to deliver a lecture, what's new in the management of chronic constipation. Since we are running late, sir, you can start.
Thank you so very much and very good evening, everyone. Dr. Arora, wonderful meeting and thank you for invite. After a wonderful talk, after Dr. Datta, Dr. Ghosal, important topic, chronic constipation. I think this is one of the most common symptoms that any human can ever have. And therefore this topic is very apt, may not be so apt for this time of the day, but so it's a very common issue. If you look at, if you ask 100 people, only 50 will say, I have constipation. But if you look at the true definition of constipation as defined by most societies, you'll find only 10% will have constipation. It means almost 50% people who say they are constipated, they don't have constipation. Constipation is a perception. And therefore, we call it perceived constipation. So what is perceived constipation? What is true constipation? And Ashish made a point sometime back that in our country, many people come that I pass 5 stool a day, but still he says he's constipated. So what is that? So constipation is defined ideally as less than 3 bowel movement per day. But many people will say that I don't pass stool every day. I don't pass stool in the morning. I have incomplete evacuation, and patient perceive all these symptoms as constipation. At the same time, many patients have a lack of vocabulary. So anything abnormal in abdomen, they call it the constipation. Therefore, constipation in our culture is an important symptom. And despite not having a decreased bowel movement, the patient says they have constipation. So second, all constipation are not same. And I give you 2 examples. A small child, the mother always say, did you pass through today? No, not today. So now he says, tomorrow pain abdomen. You didn't pass through yesterday, therefore you have pain abdomen. The child gets psyche from early part of life that I must pass through every day. If I don't, this is abnormal. At the same time, the other child who really have a disease like colonic pseudo obstruction or colonic motility disorder, this child will not pass stool despite of mother saying that. So our perception in our country that must pass stool every day, that's a problem. So those who have perceived constipation, there's no need to investigate and just simply educate them and reassure them, give a little more of bulk in the diet, and asking them to utilize gastrocolonic reflex is a wonderful thing to do. That ask them that to pass stool after meals, after half an hour after meals, and it is twice a day. And if they do so, many patients do respond. I tried myself, and it does work for some patients. So those who have perceived constipation, nothing to be done. So how do I know what is perceived and what is true constipation? And look at what we decide on 2 factors. The first factor number 1, is symptom complex of constipation. And second, stool characteristics, which Dr. Gusal already alluded to. Look at these two symptoms. True constipation, if we have two of these 6 manifestations, what are these 6 manifestations? Less than 3 bowel movements per day. Patient has to strain, hard and lumpy stool, like type 1 and type 2 on Bristol, sense of incomplete evacuation, sensory block it, and somebody has to use finger to remove stools. So these are the worst type of symptom, and they're surely they are true constipation, no doubt about it. And this will be for 3 months, last 6 months. So important, look at the stool characteristic is important, which will help us to know what is the cause of constipation. Second point, stool characteristic. And this, I believe this is very, very important to know the stool type. It's easy to put this picture in your outpatient, and it helps a lot. It will answer Ashi's question immediately. 5 stools, but stool like this. So this won't be constipation. This will be diarrhea type. This is constipation because patient knows only 2 word. He doesn't know diarrhea. He's a constipation. So passing stool like 6, but still say constipation. Therefore, type 1, type 2, surely constipation. Dr. Uday just said type 3 for our country may be constipation, but type 4, 5, 6 certainly are diarrhea. Why to know this? This tells us the stool content, the water content in the stool, more stasis in the large intestine, more drying of stool. So if you have longer stay of stool in the colon, they will be type 1, type 2, because they are dehydrated stool, and others are hydrated stools. So moving further, stool diarrhea is important. So coming to constipation, why did that occur? 3 important factors. Factor number 1, that the tract should be good. There's no disease there. There should be good motility of intestine. And third, the evacuation process should be good. But in addition, there are multiple other factors which also plays in constipation. Because of time, I will not go in details of that. But since the talk is on therapy, so for therapy, we must know what type of what a constipated patient has. 2 types, functional and organic. And of all constipation, 80 are functional, only 20 are organic. And all those functional, again, we have 3 types: normal transit type, slow transit type, and pelvic floor dyssynergia. And this is very important to find out difference between these 3. And I can tell you, those people who do not have urge to pass stool, they have stool goes for after 5 days, still don't have urge, they have slow transit constipation, but advanced stage. Those who have to use their fingers to remove stool, they are most likely pelvic floor dyssynergia. Those who have a recurrent stools, they have a small volume stools, pain abdomen, lower abdomen pain, they are pelvic floor dyssynergia. And we all know mechanical causes. So it's very important to differentiate between these 2, because if you give a wrong therapy, then patient will have more symptoms. Suppose somebody has pelvic floor dyssynergia, give fibers to them, which are commonly used, they will have a further worsening of symptoms. Rather than getting better, they will become worse. So if you have a patient coming with constipation, few things must be done for all patients. Education and reassurance. This is a disease is not going to kill you, but it affects a lot to their mind. And many patients remain quite disturbed because of this symptom. And again, to use a gastrochronic reflex should be done by everyone. So principle of therapy, and I come to what is new in that. Principle number 1, the tract should be patent. The stool should have good bulk and should be not very dehydrated stool. Stool should have good water content. There should be appropriate motility of intestine, and there should be appropriate defecatory apparatus. All of them are required for a good passage of stool. And there are some new therapies like neurostimulation, acupuncture, and FMT. Coming first to patent tract, all of us know that if there is somebody kind of disease in the colon or small intestine can lead to constipation. I'm not going to dwell upon this. Second comes stool bulk and water content. And this is very important. And again, for this, we have most of the drugs which are the main first-line therapy for constipation are here. And these therapies are basically bulking agents. We all know hypersmolar agents like polyphenol glycol, stimulants like Dulcolex, or bisacodyl or sodium picosulfate, stool softeners, lubricants, enemas. So these are first-line therapy. Second-line therapy, which are newer class of drugs, that calcium channel activators and many others. We'll come back to that in one by one. So we all know first-line therapy, so I will not dwell much on that. Fibers are very important, but fiber in our country may not be the right thing to do in patient with constipation, because as Dr. Gosal already said, we are vegetarians, we have a high FODMAP diet, we have a only good amount of fibers in our diet. So adding fiber may not be good to each patient. Fiber must not be given to those patients who have a pelvic floor dyssynergia. Hyposmolar agents are wonderful drugs, class of drugs, including polyethylene glycol, which is one of the very important drugs to be used, and lactulose. Stimulant, sodium picosulfate is a drug which is a wonderful drug, and bisacodyl, and many others. Second comes water content. So how do we increase water content in the stool? If you drink water, a lot of people do water drink, 2 glasses of water in the morning, they go to washroom, they have good evacuation. But this water is just like an increase of gastrocolonic reflex rather than increase of water in the stool, because water will be absorbed in the duodenum or small intestine. So this water will not reach large intestine to hydrate the stool. So for that, we need to do something else. And for that, we need to understand how we can put water in the large intestine. And there are 2 ways to do that. That you inhibit water absorption in the large intestine, or you add water in the large intestine by some drugs. And it's good to know about this, that in the small intestine and large intestine, there are multiple channels. The multiple channels, sodium, potassium, sodium, bicarbonate, chloride channels, and all these channels maintain the water in the large intestine. So can we use these kind of channels for increasing water content in the large intestine? And again, there are drugs. One class of drugs is called calcium channel activators. So they will increase water content in the large intestine. And again, there are 3 drugs in that. The one most important drug is lubiprostone, which is now available in our country, which can be used for increasing water content in the large intestine. So there are studies to show in the meta-analysis that this drug is more efficacious compared to controls. I'll come back to that sidelines of these drugs again. And the doses are 25 micrograms twice a day for functional constipation, and for IBS, it is 8 micrograms twice a day. Other drug is called linaclotide. This drug is not available in our country. And again, this drug also shows that there is a better compared to placebo. The third drug is plicanatide. Again, this drug is not available. Again, 2 RCTs shows this drug is better than controls. But mind, all these drugs are just minor difference. 21% in drugs, 10% in placebo. Just delta is just 10. Therefore, NNT will be quite high. And one other important drug which is coming, which looks very promising, is tenofovir, which works on sodium hydrogen exchange inhibitor. And the efficacy, you will see that 61% in those patients who receive this drug and 34% in control. Delta is quite high. So this drug is likely to be a good drug for using water content or increasing water content in the large intestine. So these are now coming to next form of therapy. So can we increase the colonic motility to improve the colonic movement and therefore constipation? Again, number of drugs. We all know cisapride, tegaserod, which are no more used these days, but the 3 new drugs which are, one drug is available for clinical use. The 2 other drugs are still in the clinical trial. So in this one drug, which is called prucalopride, which is available in our country, which is a 5-HT4 receptor selective drug, and the doses are 1, 2, and 4 milligrams, which give once a day. A systematic review of 6 trials shows that this drug increases bowel movement per day in almost half of patients. So this drug is an efficacious drug. Other class of drug is if more bile in the intestine, we know bile is diarrhea. So if somehow there's more bile in the intestine, it will also lead to kind of improved constipation. Or therefore, the receptor bile acid absorption if they inhibit the receptor, we have more bile. And the drug is ilobibexibate, which is a class of drug which is again not available, but data shows that it is better than placebo, but delta is not very high. One important drug which I've been using for a long time in Parkinson's disease, that is a cholinesterase inhibitor. So this drug is not for kind of general use, but this can be drug only for those patients who have a refractory constipation. And pyridostigmine, we have used pyridostigmine for those patients who have a chronic interstitial obstruction, and this drug is quite useful in those situations, but not for typical constipation which we use. Last is if there's a defecatory apparatus which is not good. So those patients have a pelvic dyssynergia. In those patients, biofeedback, I think all of us know, biofeedback is the treatment for these patients. It's important to recognize that 1/3 of our patients who have a chronic constipation have pelvic floor dyssynergia. How do I find this patient have pelvic floor dyssynergia? 3 or 4 symptoms. If they have a feeling of incomplete evacuation, they go to washroom, they have to go again. Means their rectum is not fully evacuated. So there's a feeling of incomplete evacuation. Number 2, if they have to use finger to remove a stool, likely they have pelvic floor dyssynergia. Or if they have a pain, persistent pain in the lower region of abdomen, this is also pointer. So if somebody has a combination of these symptoms, one can think this is a pelvic floor dyssynergia. And these patients must not ever be given fibers. Fibers is going to worsen their symptoms. And for them, biofeedback is the treatment of choice. The new thing that biofeedback now is available. There are models that biofeedback can be done at home also. Other new thing which has come up in this sphere is fecal microbiota transplantation. I think this is a kind of fashion these days that you use this kind of therapy for any kind of disorders. And this is a small study from China where 52 patients who have a slow transit constipation, not usual, slow transit constipation, if they give a FMT by usual route, there was at 4 weeks, 50% patient had a more than 3 bowel movements per day. And at later, as the time passed by, there were decrease in frequency. We don't have long-term data. At this point of time, we cannot say that FMT has any role in treating constipation, especially of a slow transit type. Acupuncture. In China, acupuncture is very commonly done for multiple indications. And this is a study from China, which is a large study of almost 1,000 patients, those patients who have a chronic severe functional constipation. And if they give their patients were randomized in 2 groups. One group were given acupuncture, 28 sessions. Other group were given SAM acupuncture. And over 8 weeks, what they observed that the frequency increased, bowel frequency by almost 2 in those patients who received acupuncture and less than 1 in those patients who had a SAM treatment. Therefore, some data to show that acupuncture might be efficacious. One other form of therapy which is emerging now is neurostimulation. Because many patients with constipation, especially those patients who have a neurogenic disorders, it's not usual constipation, but those who have a slow transit constipation because of lack of neurons. This is called neuropathy, like diabetes or hypothyroidism or congenital disorders. In those patients, there's a data to show that neurostimulation may have some efficacy. There are early studies, small trials, especially in children, but also in adults. And that data shows that there could be some improvement in their spontaneous bowel movement. There are 3 forms of therapy. One is called sacral nerve stimulation, where a device is placed at S3, S4. The catheter are placed like as you place the catheter for what we call pacemakers, and they can be stimulated from outside. Other form of therapy, this is invasive. 2 other non-invasive are that there are stimulators. There are stimulators which are to be born around this region, around the pelvic region, and then stimulation is given externally. And other one is arterial number stimulation. And there are data to show that this kind of therapy might be effective, but not for all constipation, but only those people who have a slow transit constipation. So we have a lot of choice which drug to use and which drug is ideal drug. There's no head-to-head study, but there's a network meta-analysis looking at all RCTs, which drug is good drug. And this meta-analysis shows that the best drug among all the newer ones is sodium picosulfate, which is a colonic stimulant. Almost half of patients will respond to this drug. Other drugs are all the other drugs are there, but among the classical drug is sodium picosulfate. Over short term and over long term, prucalopride has been found to be most efficacious. But if you look at the only in 18%, not more than that. Further, as a clinician, we need to understand if I treat, how many patients do I treat, and how many to get one response, how many patients I need to treat. That's called NNT, number needed to treat. And we're surprised to know and happy to know that our classical drugs, like usual first-line drugs, are still the most efficacious drugs. Look at osmotic stimulant, polyethylene glycol are much better compared to the newer drugs. So you need to treat less number of patients, but get more response. So neoclassical drugs are wonderful, but the response rate is not as good as your neoclassical drugs, old class of drugs. So though there are some patients who do not respond. So please look at if we're using proper kind of therapy in them. And we must focus on pathophysiology and titrate treatment accordingly and modify all the modifiable factors. So coming to summary of what we have talked about, if somebody has constipation, you say is a functional constipation, 80% are functional, then the first line therapy is the best therapy for most patients. Fibers, polyethylene glycol, liquid paraffin. If they don't respond, you can use a stimulant, you can use prucalopride, you can use a calcium channel activator. But still the first line is our classical drugs. If somebody has slow transit constipation, then give a lot of water to drink, ask them to go to washroom post-meal, and then use in these patients colonic stimulant. Bisacodyl or sodium picosulfate are the ideal drug. One can also use prucalopride. Use combination. You maybe use a prokinetic plus some kind of other laxative. And if no response, you might use pyridostigmine. Then some patient will require more other interventions. Peripheral dyssynergia, no fibers, biofeedback is the treatment of choice, and 2/3 patient will respond to biofeedback. And also some exercises. So in summary, we need to, once it's a patient constipation, the first question to answer is a true constipation or perceived. Perceived, reassured. True constipation, investigated and treated. With that, I'll stop and take any questions. Thank you for your attention.
Excellent talk, Dr. Makaria, very comprehensive. I think I would like to invite questions from the floor because we're getting late for the next.
Dr. Makari, yeah. From the very beginning, I did not understand the concept of perceived and true constipation, because all symptoms of DGBI disorders are perceived. So incomplete evacuation also is a perceived symptom. So if a patient feels like he has a symptom and he comes to a doctor, then he is the patient. And if he doesn't have, if he fits in with the functional category of constipation, then those patients, where did they go in the study? Were they other functional bowel disease, or there was some other disease which were not even sort of functional bowel disease or DGBI?
So I mean, this is very important to understand. As taking Asis's point, he made last time that somebody coming to your clinic say, I have constipation. Ask how many times you go to washroom. Say 5. How much stool you pass? Good amount of stool. So where the constipation? So if in this patient keep treating them is not about the bowel movement.
We have not classified them into a disease, but actually they are the.
So this is normal. This is normal. This is normal. We must reassure rather than giving
if the
pharmacotherapy.
patient has come, Dr. Ghoshal would enlighten He has come to us. He has a perceived problem. He has a disease. That's the basis of all the DGBI disorders. Then we investigate. So have you followed those patients? Do we know what has happened, or do we relegate them as non-patient and send them home? I just a question. I think it's the answer is more
No,
sort
no,
of
I mean,
philosophical.
it's important, as a physician to understand this, that in our country, our culture of bowel movement is very important. That's why I gave a story of a mother till a child. So you will see that you will see somebody, patient learn from early part of life, yeah, I don't have bowel movement every day, I'm not well. I have a heart attack because I don't have a bowel movement every day. So everything related to bowel as our culture. So the important to understand, somebody have a 3 stools a day, why do you treat them?
It's more of a philosophical thought we'll talk later. Yeah. But if a patient comes with the symptom, he is the patient. So we want to sort of not classify him, doesn't mean that he doesn't have a disease. We are not able to classify. That's the
As a
problem.
physician, if you understand, then it's good to tell the patient rather than give him pharmacotherapy. It's not easy, but good to do that. Good to do that, yes.
How do you manage chronic pseudo-obstruction, colonic pseudo-obstruction vis-a-vis severe chronic constipation?
Pseudo obstruction, how do you recognize first? Somebody has a bowel movement, pseudo obstruction will occur over time. So the first part of life, pseudo obstruction symptom will be overlap with the typical functional constipation. We can't differentiate unless you do imaging studies or do chronic studies. But at the time we have an advanced disease, the colon is not moving. First thing will happen, the colon doesn't move, rectum is empty. The rectum is empty, they won't be urged to pass out. The patient will not go to washroom for 4 to 5 days, still no urge. This is not chronic severe constipation. This is a pseudo obstruction. This is a not pseudo obstruction. I would say chronic motility disorder of intestine with organic type. And this patient, two things will happen, and that's very important to understand. That if the distal colon will be full of stools. You do X-ray, you find all filled with stool. This patient, whatever I give, not going to work. I need to clean. I need to push force from top. Means in this patient, you have to give pulse and glycol days and months together, so that some movement occurs, stool moves out to the rectum, right? And this patient can then in a form of therapy will work. Somebody has fecoloma, whatever you do, nothing going to work because there's a distal obstruction. Only you have to clean distal obstruction before any drug will work.
So one small comment, apart from all the measures you told, increase water and all that, even the position in which the patient sits, that is also sometimes important. The squatting position helps rather than the sitting position. So just one comment.
Sir, your expert comments regarding the role of fiber, particularly in the slow transit constipation, how whether it's help or worse.
So transit constipation give fiber going to you're increasing stool bulk. So the colon is not moving, you're increasing bulk further. If you look at the colon, if you do X-ray, you find these patients already have a lot of stools, and stool is staying there for a longer period of time. As they longer they stay, they become dehydrated. Therefore, dehydrated stool will not pass further. Therefore, giving fiber is not good therapy to them, right? So in this patient, give combination. Allow colon to move, sodium picosulfate or Dulcolex or bisacodyl, and also give push force from top. So contraction and push force. Push force from top means pulse and glycol.
In interest of time, we wind up this session and we thank Dr. Govind Makharia for excellent lecture.
So last one more. So just use of peppermint oil in IBS predominant constipation.
There initial studies available are there. People still use peppermint oil is very commonly used in our country, and but there are no systematic studies. Early studies are there, especially for IBS pain predominant, but I'm not sure it work in constipation.
Thank you so much. Thanks.
So can I request you for a picture, please? For the last session of the evening, can I please invite Dr. Alok Gupta and Dr. S.P. Mishra to please moderate this session. Dr. Anita Sharma, Dr. Naresh Agarwal, Dr. Binod Karki, and Dr. Bibek K. Purvi to please chair this session.
May I, without wasting any time, Dr. Puri? We all know Dr. Puri very well. He is now in Medanta. He was the chief of gastroenterology at GB Pant Hospital. And he'll be speaking on recent advances in NET.
Good evening, everybody. I'm well aware of the fact that I stand between you and dinner, and both of us will therefore have an urge to get through this quickly. But at the same time, I must congratulate Dr. Anil Arora, because the first day, first show, the population is the same as first day, last show. So that speaks volumes for his conference. But for today, in the next 20-25 minutes, I'm just going to run through the neuroendocrine tumors. As you're well aware, the neuroendocrine tumors, vast subject, can occur anywhere in the whole GI tract, including the pancreas. And so my focus is largely on the pancreas, but of course, I will be touching on the common areas of the lumen as well as the pancreas. The way I look at neuroendocrine tumors is very similar to what Oberdorfer, what he said. Well, this looks like carcinoma, but it's very indolent, so we got the name carcinoid. So carcinoid, and now of course it's known as neuroendocrine tumors. The way I see it, it is like volcanoes. So there are some volcanoes which never erupt. For example, I don't think the Fuji has ever erupted in the last 200 years or so. And some of these tumors, the person lives with them and dies with them. He doesn't die of them. There are others which are smoldering, you could say, and that one can compare with local invasion. And once the volcano erupts, which means METs have occurred, then it's probably too late. So with this background, I'm just going to start my talk. We had several sessions on IBS, and it's very important here. This was a paper that was published about 12 years ago in Pancreas, and it said many of these patients who come with non-specific vague symptoms actually were those of the neuroendocrine tumors. So in this paper, they showed clearly that almost 12 years was the time that the correct diagnosis was made. So that is the lesson, that we must diagnose them in the early stage, in the dormant stage, and not when the volcano has erupted. The current classification of neuroendocrine tumors, JEPNET, where G is gastroenteropancreatic, two broad categories. One is the pancreas, because they have a different presentation. They are associated with functional tumors and non-functional tumors. And the others is the non-pancreas, which can involve the stomach, intestine, rectum, for unknown reasons. Rectal carcinoid, not very common in India, but very common in the Far East, in Korea and Japan. I brought this slide specifically because not only to show the epidemiology and the distribution, but what is the perspective. So this paper from Dr. Srikhande's group, Tata Memorial Hospital, is from a surgical perspective. The one in the middle is late Dr. Amrapurkar from a gastroenterologist perspective. And the one on your left, extreme left, is from AIIMS, from the nuclear medicine department. So three different perspectives. And let's see what's common. So what you can see very nicely is that turquoise blue is the dominant feature, whether it comes from Dr. Srikhande's group or from the Bombay Hospital or from AIIMS. So the turquoise blue is the pancreas. But look at what happens from a gastroenterological perspective. Almost 30% of the patients were gastric. That's because we keep on doing the upper GI endoscopies. We picked up so many carcinoids. So that is why that big green segment in the pie chart from the Bombay Hospital. And from the nuclear medicine, you could see the green becomes very less because there are hardly any patient. It's only the advanced neuroendocrine carcinomas are going to go to them. The type 1 gastric carcinoids, which are just small pebbles in the stomach, they would never be sent for it. So this is the various perspectives. This slide, I wanted to give a perspective that the bulk of pancreatic tumors is the ductal adenocarcinoma. So neuroendocrine tumors is a minuscule, probably just about 2%. And that also, there is a segment, the subset, which is neuroendocrine carcinoma, starts behaving like a ductal carcinoma. So neuroendocrine tumors constitute just 2% or a very small minority of all pancreatic tumors. Going on to the clinical classification of the pancreatic tumors, it depends on which hormone is being secreted. So depending on that, you add the word OMA. So if insulin is being secreted by the tumor cell, it becomes an insuloma, vipoma, and so on and so forth. The important thing to note in this slide is in the last 30 to 40 years, what has happened ever since cross-sectional imaging came, there's been a change. Initially, it was thought that functional tumors of the pancreas are much more common, but the widespread use of the cross-sectional imaging, specifically the CT and the MRI, said that the non-functional pancreatic tumors now constitute at least 80% or even more, and only about 10% of the pancreatic tumors are functional. From a pathological perspective, the pathologist will tell us two things. One, is the neuroendocrine tumor well differentiated? Can I have a, it's not showing here. So from the pathological, what the pathologist tells us is that what is the differentiation? Is it a well differentiated tumor or is it a poorly differentiated? So if it's poorly differentiated, it automatically goes into the neuroendocrine carcinoma. The volcano is erupted, it's too late, and in all likelihood, this patient is going to have a metastatic disease. But it's important to note that a small subset of patients with well-differentiated neuroendocrine tumors can also have a high mitotic count, which can be 2 to 20, and a high K167 index of again 3 to 20%, and they become G2. So the grade becomes G2. And a very small subset of these will also, it's a well-differentiated tumor when she looks at it in the path. But when you do the Ki67 and the mitotic count, it's more than 20 for both. So that means that even a well-differentiated neuroendocrine tumor can be G3, and this is more likely to behave like a neuroendocrine carcinoma rather than the well-differentiated neuroendocrine tumor. The two popular stagings for pancreatic nets, the European is the E-nets, what we follow in Medanta and elsewhere. I think what is more popular is the aegis, which classifies on the basis of the size of the tumor. So if it's less than 2 centimeters, then it is a T1 lesion. More than 2 centimeters, it becomes a T2 lesion. If there is local invasion, but not invasion of the major vessels, it becomes T3. And T4 means major vascular invasion. So if you have a T4 lesion, automatically you become a stage 3 lesion. So the only ones that we get in stage 1 are probably the gastric carcinoids. They are the ones you're most likely you're going to see stage 1, at the most in stage 2. And as I said earlier, once you reach stage 3 and stage 4, then most of these patients cannot be taken up for any curative therapy. For the sake of brevity, I'm just going to discuss 3 functional tumors of the pancreas. And these are our cases that we have picked up. So in insulinoma, the peptide that is secreted is insulin. 99% of insulinomas arise in the pancreas. The malignant potential is less than 10%, and they are most commonly in the head. And the malignant potential is less because these tumors are symptomatic. And because this hypoglycemia is such a symptom that it cannot be missed, so therefore the tumor is picked up earlier. So and the patient is going to come to you. And when I say that the patient is going to come to you, it doesn't mean the gastroenterologist. The gastroenterologist is probably the last stop. So most of these patients, because of their hypoglycemia, They have seizures, they are sent to the neurologist, they are seen by the neurologist, sends them to the endocrinologist, and then finally they would come to us. And this is one tumor in which, now what does one associated malignancy or a tumor with? Somebody who's cachexic, thin skin and bone. But these patients, perhaps the only two exceptions that I know of, is these patients are obese. And to bring home this point, this is an 18-year-old girl. She weighed about 78 kg, and she had repeated episodes of hypoglycemia. And as I said, the route that she took was repeated episodes of admissions in neurology before she was finally referred to us. What you can see in the center is a triple phase CT, and that shows a tumor over here in the head of the pancreas. And when we did the PET scan, nicely lighting up the tumor. As you can see, this was a success story. The patient underwent a surgery, and at the end of first year, approximately, she had lost about 18 kg, and she became thin. Not that she became size 0, but she definitely lost weight. The next patient, the next functional tumor that I'm taking is the vipoma. The peptide that is secreted is VIP. The site is again pancreas at 90%, and perhaps one of the most malignant tumors of all the functional tumors. And typically, these patients present with diarrhea and weight loss. The typical situation of the pancreatic vipoma for unknown reason is that it's in the tail. So if you have a tumor in the tail of the pancreas, then it is in all likelihood, neuroendocrine tumor in the tail of the pancreas is in all likelihood going to be a vipoma. The case that I'm discussing now, again, this patient didn't come to us. This patient, because of the severe hypokalemia, was referred, developed quadriparesis, a hypokalemic periodic paralysis, 3 admissions with the neurologist, and finally ended up with dialysis because of the severe dehydration, pre-renal azotemia, ATN, required dialysis before the correct diagnosis was made. And the clue to the diagnosis was the severe hypokalemia. Again, if you can see, that's the tumor right next to the spleen. The spleen is an innocent bystander, but when the surgeons do the surgery, they sacrifice it. I will show you that in my next slide. And here you can see a large tumor in the tail of the pancreas abutting the spleen. This was another success story. And as you can see, as I was talking, the innocent bystander is the spleen, had to be sacrificed. That's the tumor. And on the IHC, it stains both for synaptophysin and chromogranin. Last functional tumor, gastronoma. And as we are well aware, the tumor mostly 90% lies in the gastronoma triangle. The triangle is defined by the junction of the cystic duct and the common bile duct, that is the apex. And over here is the junction of the D2 and D3. Now, this point actually is the neck of the pancreas. The neck of the pancreas is not a line. So technically, this should have been a gastronoma quadrangle. But everywhere it is referred to as the gastronoma triangle, and we leave it as that. When my resident showed me this picture, so I said, surely this patient has had a corrosive income. He said, no, there's no history of corrosive. And it was obvious. So the amount of excess HCl that is damaged, you can see they're all gangrene over here. This is all necrotic tissue. So this is exactly what you happen or what we see when the patient, they come with corrosive injuries to the duodenum. This is the exact picture you can change between the two, and almost a telltale when you see this patient. One of the dominant features of classical features of the carcinoid syndrome is the flush. So these slides have been sent to be my resident, and this young lady, she used to get flushing to such an extent that she was thought to be psychiatric, and she was labeled as she was malingering, and they even said that that she smears her vermilion on the face, and that becomes obvious. This is her full flush. You can see it looks as if she's taken the vermilion from her head and put it on the face. So this is unusually, this was associated with the type 1, type 3 gastric net. Now coming on to the investigations of neuroendocrine tumors, we have at least 5 modalities: serum markers, hormone markers, which I partly discussed, the scans, octreotide and the DOTA scans, cross-sectional imaging, and the EUS. I won't be talking much on EUS because that's a separate issue altogether. Let's take the biomarkers. I've already discussed the specific biomarkers, the hormones, gastrin, insulin, VIP, etc. The non-specific, which are used as screening tools, is chromogranin and synaptophysin. Chromogranin A is used as a first-line diagnostic tool, and it is secreted by well-differentiated neuroendocrine tumors. So if you have a neuroendocrine carcinoma, it's not going to secrete the chromogranin. The levels will not be high. This slide shows that there is a relation between the hepatic tumor load once it is metastasized. The greater the tumor load in the liver, the higher level that you can see of the gastrin. It is important to know that there are certain false positives, and the most important is PPI. This is a common mistake. And please read this slide from below upwards. So you can see over here, this patient is a 78-year-old lady who's been having a diarrhea for about 3 to 4 weeks. She's been on PPI for the last 3 months. So now she's been advised a PET CT, a DOTA PET CT, because her chromogranin levels are 350. And if you look at the top, that's the clue. IV pantoprazole, she's been getting in this hospital stay for about 7 days, and prior to that, another 2 months. So that would explain her high level of chromogranin. So any patient recommended is 2 weeks to be off PPI before you get a chromogranin estimation, minimum 1 week. Before discussing the role of the octreotide scans and the DOTA scans, this is just an artist's impression. What you see is a sphere with lots of spokes on them. And sometimes I see teenagers with this hairstyle. It's called spikes. But if you look carefully, then each spike is not cloned. So some are big, some are small, some are bifid. So all different types of spokes that you can see over here. And these are the somatostatin receptors. There are 5 varieties of them, type 1 to type 5. And what we pick up on the octreotide scan is only type 2 and type 5. 90% of the neuroendocrine tumors have these surface somatostatin receptors, which are coming like the spikes on these guys' head. But when the tumor becomes a neuroendocrine carcinoma, then these disappear. So these patients will not be picked up once they go into a neuroendocrine carcinoma. And even in that, let me tell you that some tumors like insulinomas, the receptors are just not there, or at least they're not type 2 and type 5. So this is the same thing. The neuroendocrine cell, the somatostatin receptors, type 2 and type 5 are picked up by the octreotide scans. And you can see glucagonoma, 100%, insulinoma, only 50%, and the others are in between. This is the structure. I thought I'd show it is the structure of the somatostatin. It's been described as a bullet-shaped 14 amino acids. But if you look carefully, then there is a spike at the end. There's a tail coming. So for me, it looks like a rocket, which we as young children on Diwali, we were firing. So that is the rocket-shaped somatostatin. And the most important part of the rocket was where you put the fuse when you light the rocket. And that most important part is the disulfide bond between the two cysteine residues. So native somatostatin, 14 amino acids, that bond is there. Then disulfide bond is there in octreotide. The disulfide bond is there in lanreotide. So any somatostatin analog has to have this bond. This is just to show you pictures. and prove the point that I just made. This is a patient who had an insulinoma, and when we did when the scan was done with the somatoscan, because it does not express, so all you see is a non-specific uptake in the liver, in the spleen, and in the two kidneys. And yet, when we did in a patient who's got a gastronoma, you can see the somatoscan, the SRS is showing Mets liver, large tumor here, and clearly the insulinoma has not been picked up. In those patients, if you do a PET scan, it's far more better, as most of it lights up. This is the tumor in the tail of the pancreas, and this is seen both on the PET scan as well as on the DOTA scan. So to summarize, what's in, the DOTA scans are in, the octrio scans are out, intraoperative venous sampling is out, and EUS is very much in. The last bit, sorry for exceeding the time, is the management. That's a three-pronged approach, because you have to manage the tumor. If it's a functional tumor, then it's secreting something, then you have to manage that hormone. And lastly, you have to manage the Mets, mostly in the liver. The treatment goal is, if it's a patient who has loco-regenerative, is curative, the surgeon, your surgical colleague, is going to help you. From a patient's perspective, he wants only control of symptoms. If it's an advanced neuroendocrine tumor, neuroendocrine carcinoma, multiple Mets, then all you can offer is palliative therapy. For the management of the primary tumor, we have at least 4 modalities: surgery, where it is possible to remove the entire tumor, debulking, or in the case of functional tumors, as much as you can remove. Second, we need to control the effects of the hormone, which I'll be talking about, peptide receptor radionuclide therapy, and lastly, molecular targets. So for the local regional, any tumor less than 2 centimeters is easy to remove. It has not spread. If it's functional, always operate, because there is no way you can take care of his symptoms until you remove the tumor. If it's non-functional, 80-year-old male, patient is not symptomatic, let him be. You can safely wait and watch like the Fuji. If it's more than 2 centimeters, then you have to consider surgery and other therapy. But if it's a neuroendocrine carcinoma, then you do not go in for any curative surgery, because it's way too late. Somatostatin analogs, very much in use, and they really pack a punch, because initially it was thought that they take care of only the hormone. 2 subsequent studies, the PROMIT study in the small bowel, showed that they also have an anti-tumor effect. And the same was proved from the Clarinet study, proved that in pancreatic nets, the tumor also regresses when you give these. So double-pronged attack from the somatostatin analogs. Just one slide on the PRRT. As you can see, there is a radioisotope, which is mostly either lutetium or yttrium. This is bound to a chelator, which is DOTA, and then the somatostatin analog, which is the peptide or TATE. And this goes into the somatostatin receptor, which I showed you, type 2, type 5. And once the whole thing reaches the target and goes onto the surface, then endocytosis occurs. And it's like a Trojan horse. Once the horse gets in, then destruction. And beta radiation is the one that kills the tumor. For systemic chemotherapy, what's out is streptozocin. What we have today, most oncology units are using temozolomide in combination with capecitabine. It's almost the standard of care. Then my last couple of slides are on liver involvement, because it is perhaps the most common site of involvement in most neuroendocrine tumors. So it is responsible for the carcinoid syndrome, and sometimes it's the only site of metastasis. So the options that we have in a patient of a neuroendocrine tumor who has METs is, what is the size of the primary tumor? Can that be removed? What are the comorbidities of the patient? What facilities are there in your hospital, and the cost? So 3 different options. If it's a small tumor in the liver, 1 or 2, you can easily resect it at the time of the primary surgery. Small size, METs, multiple, RFA, provided they're not subcapsular. And if it is multiple METs, large, then it's embolization. The principle of embolization is the blood supply to the malignant cells is from the hepatic artery, to the normal healthy cells, non-tumor cells is from the portal vein. This is about 20%. So if you take off 20%, not much damage to the liver, and you hopefully kill the tumor cells. You can do a bland embolization, you can target doxorubicin, and you can use radionuclide. My last slide, practically, what is new in 2020 is sunitinib, landmark article in the NEJM. That was almost about 5 years ago, so it's nothing new about it. The new drugs are the signaling inhibitors, mTOR. We were using everolimus for liver transplantation, and suddenly we found because of the signaling, it is effective even in neuroendocrine tumors. 3 at least different pathways, immunomodulators, immune checkpoint like we use in HCC and epigenetic. As all these drugs are still encoded, no drugs names as yet. I've just put them as VE800, etc., and not go any further. And finally, the last, prognosis. So it also depends on what is the site. So obviously the best prognosis is those tumors on your extreme left on the appendix. The rectum has good prognosis. The worst is once you have liver mets, and everything else is probably in between. So to conclude, ladies and gentlemen, I'd just like to say that the time to act is early diagnosis. And if you wait for the volcano to erupt, then you kindly miss the bus, and the patient is not going to have a good outcome. Thank you very much. I'm very aware that I took extra time, and it's between your dinner time.
Yeah. Just a very exhaustive presentation, Dr. Puri. Congratulations. All those patients that you had mentioned, like what was an average delay by the time like they presented and then we diagnosed them of these?
So see, it depends on what the symptom is. For a patient who's having a vipoma, whose stool output is going to be more than 2 liters per day, it's going to be a short incubation period, because not only has he got the diarrhea, he's landed himself into hypokalemia, gone into dehydration, requires dialysis. So the situation. But the others, for functional tumors, it is much less. For non-functional tumors, it can be years.
Thank you. And flushing is not only caused by NET, flushing is also caused by alcohol.
Okay.
So, waiting for you.
Thank
you, Dr. Puri.
Thank you.
Thank you.
So can I request you for a picture, the center of stage, please? The dinner is ready. I request you all to please proceed to the lobby. We will begin sharp at 7:55 tomorrow morning. Looking forward to seeing you all. Thank you.